دكتورة فايزة، السلام عليكم. دكتورة فايزة، السلام عليكم.
وعليكم السلام.
Would you like to share your screen just to see if it's moving smoothly, please?
شو طيب واضح.
Can you please make it full screen?
شور.
Please move forward couple of slides. ممتاز جدا، ممتاز. Thank you very much, دكتور. Thank you.
أهلا وسهلا. Should I leave it?
No. Please disable.
Okay, sure. Thank you.
Ready? 1000? Okay. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. Assalamu alaikum and good afternoon everyone, and welcome to our 5th annual Precision Oncology conference. It's my pleasure to chair this conference with my dear colleague Dr. Kanan Shemmari, consultant medical oncologist and deputy chairman of the outpatient department at King Abdullah Specialist Hospital for Children, and he's also director of MENA NCCN Coordinating Center. Our objectives for this meeting is to review the most recent applications of precision oncology across different tumor sites, to enhance the understanding of basis of genetics and genomic among healthcare provider. And we're going to have a live molecular tumor board case discussion that we've been doing for the last 3 years. We have a wide group of audience. We have a limited seat for physical attendees. However, we have more than 1,000 already joined through the Zoom. And also we have live streaming also as well through our application. And I invite everybody to join through the application if you want to see the live streaming of the meeting. This, our dear scientific committee and organizing committee, thank you for all their efforts, and thank you for our faculties who accepted to join us on this conference. We'd like also to take the opportunity to thank our sponsors, Pfizer, Amgen, Merck, and Menarini Streamline. And we would like to start our first session. It's my pleasure to invite my dear colleague, Dr. Marwan Al-Hijali, who's a senior consultant medical oncologist at King Abdulaziz University Hospital, and Dr. Riham Ajina, who is a assistant professor at King Saud bin Abdulaziz University for Health Sciences. So please, Dr. Marwan and Dr. Riham.
So our first speaker for the discussion is Dr. Faisal Al-Baby. Dr. Faisal is assistant professor and teacher at the University of Health Sciences.
Dr. Faisal, can you hear us?
Yes, we.
Thank you.
Assalamu alaikum wa rahmatullahi everybody. Thank you, Dr. Riham, for the introduction. First, I would like also to thank the organizing committee for their invitation to present at the 5th annual Precision Oncology Conference. I will today talk about the evolving biomarker in immuno-oncology. And before we start, I think it's very important for physicians and scientists to have a very clear understanding of cancer immunocycles, in particular, how cancer immunophenotypes influence response to immunotherapy. Typically, when tumors arise in the body, it will start release a new antigens or mutated new antigen that will be picked up by an antigen-presenting cells. These cells will then traffic through the lymphatic system to the lymph node, where they're going to encounter, prime, and activate T cells. After activation, T cells will traffic back through the lymphatic system, to the tumor microenvironment where they're going to interact. And so this is very critical steps, how these immune cells interact with the tumor cells play a very big role in their likelihood to respond to immunotherapy. Clinically, we can divide this interaction based on the cancer immunophenotype. And the first here on the right, you can see a section of tumor cells, what we classify them as an immune desert. As you see in the figure, you barely can see immune cells within the tumor microenvironment. Unfortunately, this type of tumor type, they are less likely to respond to immunotherapy because of the lack of presence of T cells. The second one is the immune excluded phenotype, which is, you can see there is a good amount of T cells surrounding the tumor, but they lack ability to infiltrate within the tumor itself. And the last one, which is the inflamed one, which is the preferred type, that's, as you see here, there is a many infiltrated successfully T cells that can interact directly with the T cells, either inside or outside the tumor microenvironment. And so how can cancer cells express themselves at that time to immune cells can really play a big role in the responsive rate to immunotherapy. So how does this process works? Typically, when mutations happen in tumors, they will get transcribed and presented on MHC molecules on the cell surface where they're going to interact or presented to the T cells. Typically, normal cells will not have this expression since these mutations are specific for tumor cells. The second class is the tumor-specific expression, like cancer testis antigen, which is upregulated by epigenetic dysregulations. And again, this will be specific to tumor cells. So what we have here actually is that the second part here, we have a low tumor specificity. So these two antigens are presented in both normal cells and as well as cancer cells like GB100, which is expressed in both melanoma and normal melanocytes. And then, of course, we have certain protein that are overexpressed on tumor cells, but they also expressed in a less abundance in normal cells. And because of their increased abundance in tumor cells, they are a good and unique target for immunotherapy. So how this interaction happen or the expression of tumor antigen can be used as a biomarker. A biomarker can be either diagnostic, prognostic, or predictive, which is the scope of our talk today. And it's important to mention biomarker is not necessarily a protein. It can be also a DNA, a microbiome, as well as an immune or stromal cells surrounding the tumor. So why is it important to predict respond? First of all, to avoid risk of adverse event. It's cost-effective care. It avoids unnecessary treatment. It can help physicians identify who's more likely to respond and benefit from treatment. And also, it helps streamline decision-making and avoid trial and error approach in selecting treatment, and can also guide combinational therapy decision. PD-L1 expression, which can be detected as using immunohistochemistry staining, is a useful, it's actually expressed in both tumor cells and immune cells, and useful but imperfect predictive biomarker for response to anti-PD-1 and anti-PD-L1 blockade. The potential use of PD-L1 expression as a predictive biomarker was demonstrated in early studies that investigated the safety and efficacy of nivolumab and atezolizumab, which provided a strong rationale to further development of PD-L1 expression for this purpose. Many studies have proposed or showed data with a good beneficial rate or response rate from tumor that express PD-L1 to immune checkpoint blockade. However, there's also a bunch of data that showed a good beneficial also in the PD-L1 negative tumors. In the left side here, you can see a patient, the author showed a patient with tumor that lacked PD-L1 expression, had a durable response rate that exceeded 24 months. In the right figure, we can see a hazard ratio of both overall survival and progression-free survival based on the PD-L1 expression. And that expression was, the cutoff was 1%, 5%, and 10%. And as you see, despite the level of expression of PD-L1, all of these tumor types respond or prefer the treatment with nivolumab compared to the chemotherapy. So the disparities in these trials drove a general sense of doubt regarding PD-L1 as a clinical biomarker in the clinic. The second predictive biomarker that we're going to look at is the mismatch repair deficiency or microsatellite instability. Typically, DNA will make an RNA, which is going to make a protein. To maintain this flow of information, our genetic DNA need to be replicated. And each time this happens, there is an increased chance of mismatch repair deficiency. In normal people, there is a natural system to fix this process. However, in some patients, they lack this system or mechanism. And therefore, they will have an increase of microsatellite instability, which lead to increased tumor mutational burden, leading to higher chance to respond to immunotherapy. It's important also to mention that the good thing about mismatch repair deficiency as a predictive biomarker, it can be detected both in early stage as well as in late stage of cancer. To identify patient with a mismatch repair deficiency, there is a 3 method used. The first one is the immunohistochemistry staining, which can look at the expression of 4 mismatch repair deficiency or protein. At least two of these protein, if they get lost, we can generally consider the patient a mismatch repair deficiency. The second one, which is the BCR, which can measure a change in the length of microsatellites, which has been standard test over 20 years. The last one, next generation sequence, which is not widely available. The first two is the widely available in most of pathology lab. And each technique, of course, have an advantage and disadvantage for the use. The establishment of MSI as a predictive response of solid tumor to PD-L1 was back in 2017 study, where they looked at 12 tumor types across 86 patients. All these tumor types has to be highly metastatic, unresectable, with an MSI high. The result of this study was outstanding. They showed an objective radiographic response in 53% of patients. The complete response rate was achieved in 21% of patients. This granted the FDA approved for adult and pediatric patients with metastatic unresectable MSI high solid tumor. MSI high has a different or unique molecular makeup. So this study, published in 2019, looked at the colorectal cancer from Memorial Sloan Kettering Cancer Center database, and they found that in patients with MS or microsatellite stable tumor, the incidence of targetable fusion was only 0.4%. However, in MSI high population or patient was 5%, and some studies reported as high as 7%. So this indicates that any MSI high cancer need, in fact, to be assessed for targetable fusion. Why is that? Well, because of their unique therapeutic outcome. This study found that patients with a targetable fusion, all-cross or NTRK rearrangement, responded poorly to chemotherapy. The median overall survival went from 3 years to almost 15 months with a target fusion. The third predictive biomarker here is the tumor mutation burden, which measures the number of DNA mutation in cancer cells, the DNA sequencing of all coding region of the entire genome, and it can be calculated as a number of mutations per megabyte. Generally speaking, more than 10 mutations per gigabyte considered as high. There are only two methods to test the MTB, which is a whole exome sequence. This is the gold standard. It can generate a large number or amount of data. However, it is expensive and required more DNA. The second method is the target panel. Although it has a reduced cost of effect, it required less DNA samples, but also can generate less data. So this study, they looked at the correlation between MTB and objective response rate in 27 tumors. The y-axis showed somatic mutation per megabyte. An x-axis showed the objective response rate. And each dot represent, the size of the dot represent the amount of patient or number of patients enrolled in this. And each dot, of course, represent a different tumor type. And as you see, the author showed a good correlation between MTB and ORR in all or the majority of these tumor types. It's very important to understand cancer biology. This will help us to suggest or come up with a potential reliable target therapy. Here in the study, they showed this figure showed a multitude of cancer, looking at microsatellite instability, to mutation burden, tumor mutation burden, and BDL1 expression. So the orange cycles the BDL1 expression, the blue is the TMB, and the green is the microsatellite instability. As you see in the figure, the majority of microsatellite instability are in fact MTB or TMB. So they also have a tumor mutation burden. However, not all TMB are MSI high. So this suggests that TMB and MSI are significantly correlated, but the BDL1 not that much. So this begs the question, is it possible to combine BDL1 expression or MSI and TMB together to make overall better predictive biomarker? In the right figure, the author tried to answer this question, and they showed that in the blue bar, you can see upper blue bar, you can see that tumor with high TMB and high expression of BDL1 had the best response rate compared to single predictive biomarker. The second graph down, they looked similarly, but with the MSI in regard to the MSI genotype. Similar result is found. So if the patient tumors had TMB high and MSI high, they will have a higher predictive response rate compared to the single therapy or single predictive biomarker. So this is another important thing also to consider. What happens to these new antigen mutations during treatment? Do they change? Do they remain the same? The authors showed that they sequence pre-treatment and on treatment 1 month after treatment. So here, this is a progressed disease patient, a stable disease, and this is a complete response. Pretty much showing a similar thing. Some mutation remain 100% the same, pre and on treatment. Some mutation disappear totally, and some appear again or appear in the tumor after resequencing. So what's the potential or the upcoming biomarker? This is an interesting review that was published recently in 2014, looking at multiple biomarkers that's under investigation. Well, ideally, looking at peripheral blood. They looked at over 100, and they collected many biomarkers that going toward the same direction. But it's important to mention that this is still at investigation, and it's not under clinical practice as of yet. LAG-3, which is currently, there are over 97 clinical trials investigating their efficacy in combinations with the PD-1 and PD-L1 blockade. At least 10 trials have been completed and published. And this granted the FDA approval in 2022 with a dual treatment of blockade along with the PD-1. So what's missing in clinical trials? This is an interesting review. They looked at phase 2 and 3 clinical trials. And the author asked whether or not the principal investigator of these trials used a predictive biomarker to enroll these patients. Well, as you see, the majority did not use a predictive biomarker. And this is actually, in fact, a big problem in the field because we need to have the rationale, solid rationale on how or why you're combining two drugs together. Ideally, these rationale need to be coming from the lab, from the patient to the lab, and etc. Historically speaking, we used to look at the tumor only and how they look like in terms of genomic mutation, microsatellite instability, and etc. But with an increased understanding of how this tumor biology works, now we're looking at tumor microenvironment, including surrounding tissues, the host, the patient, their BMI, their gut microbiome, and their metabolism, also to the peripheral blood. So we have to look at all these factors together. So can we put all this together, ideally to develop a robust predictive biomarker? It's important to mention and keep in mind that this is not a standing thing. It is a moving target. Tumor is dynamic. It's not ideally the same. There are no tumor are the same. Lung cancer is different from liver cancer, from melanoma, for example. And also one cancer type, it differs in region. So the right region of, for example, pancreas is not like the left region of pancreas. So you can see how this is proven to be a very complex task to address. So what makes an ideal predictive biomarker? It has to be highly accurate. It should accurately distinguish between patients who will respond and will not respond. The minimum invasive is very important, and also the robustness and reproducibility. The biomarker need to be validated in different lab, different cancer, different patient as well. And it should also allow a physician to monitor a patient or tumor progress over time to track the treatment response and any emerging resistance. To conclude, the big question remains, can we predict who will respond to immunotherapy? The short answer is no, not as of yet. While prognostic biomarkers have been validated and clinically informative, predictive biomarker, though, used in some setting now remains insufficiently robust for routine clinical decision-making. These biomarkers need to be validated so we can be confident in our treatment decision-making. With that, I would like to thank you all for listening. You can reach out to me over my email or my X account if you're interested in research or higher educations. And thank you so much for listening.
Thank you, Dr. Faiza. Great talk and outstanding review. We'll keep the question till the end of the session, and we'll move with the next speaker, Dr. Hisham Badruddin. He's the director of the Saudi Biobank at King Abdullah International Medical Research Center. He's an associate professor from the Pharmacy Practice Department. He will be having actually a discussion about biobank and precision oncology, the KMARC experience.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين. Jum'a Mubarak, everyone. First of all, thank you so much for your kind invitation. I would like to extend my appreciation for the scientific and organizing committee led by Dr. Muhammad and Dr. Kanaan for inviting me to this esteemed and prestigious conference as usual. So today, as you guys can see, I'll be delivering a talk about the Saudi Biobank and our experience, and I'll try to shed some light on the role of the Saudi Biobank in precision oncology. I'll share some insight about some of the projects that are currently ongoing and some of the future projects that are going to be launched soon enough. So before I go ahead and get started, I realize that some audience might not be familiar with the concept of biobank. So what I'm going to try to do in the next 5 to 10 minutes, basically, is try to summarize the background of biobanks and shed some light on the historical component of biobanks. So in 2009, the Time magazine published a report about the 10 ideas that ultimately will change the practice in the next 2 to 3 decades. And by far, one of them was the biobanks. And for those who don't know what biobanks typically are, biobanks as a word stemmed from one of the papers that was published in 1996 by Loft and Paulson. And they first utilized the word biobank to refer to the use of human biological materials in order to store them. And ever since, the concept of biobank started to emerge and started to continue to evolve until we had a unified definition for the biobanks. And it's when we say the word biobank, we refer to a collection of human biological samples and its associated information, and they are organized in a systematic way for research purposes. And here, I'm not talking about one blood sample. I'm not talking about a couple of blood samples. I'm not talking about a rack of blood samples. I'm talking about hundreds of thousands of blood samples that are ultimately organized in a systematic way. And that field has continued to evolve, and much of the evolution that we've witnessed in the past couple of decades was basically stemming from the advancements in the multi-omics fields. We're talking about advancement in genomics, proteomics, transcriptomics, and epigenetics. All in all, that was also pulled in the major advancements in the electronic databases that can store this huge amount of information. So if you're thinking about any projects that ultimately have certain outputs from genomic components, you're typically talking about massive amount of data that you will be required to store them. So with that, let's look at geographic representation and illustration of the current biobanks globally. And as you guys can see, most of the biobanks are currently located in North America and Europe. Some of the notable ones, we're talking about UK Biobank. Most of the advancements that we currently have in our daily practices are coming and stemming from the UK Biobank. We're talking about all of us located in North America, and most of the research that gets to stem from North America is basically coming from all of us. And from the Middle East region, not until recently, we used to have Qatar Biobank, and more recently, we started to see more biobanks getting to be established and launched in the Middle East region, including the ones in Abu Dhabi and in Dubai. And if we're talking about cancer, we cannot talk about cancer without mentioning the IARC, or the International Agency for Research on Cancer, related to the WHO, and it's considered one of the largest biobanking cancer globally. Now, if we take a look at the representation of the current biobanks that we have in Saudi Arabia, we have the one in Kmart, which is called the Saudi Biobank, and I will be mainly shedding some light on the Saudi Biobank. We have the one in PNU, we have one in Mapai, or the Public Health Authority, we have one in King Fahd Medical City, and King Faisal and in Taos. So all of these biobanks have different objectives and different aspirations compared to the other. Now, all in all, collectively, what scientists are looking for, they're looking for the availability of large collection of samples, and ultimately these patient-collected samples has to be annotated and connected to certain information, so that ultimately we can journalize them and utilize them in our projects. And when we're shedding light on the cancer field or in the oncology field, I'm talking about samples that could be collected at any stage of the patient journey during their timeline whenever they hit the door. We're talking about patients who did not develop the phenotype. We're not talking about someone who developed the actual cancer. We can have certain samples that have been historically been collected. Once we discover that they have certain tumor, we can collect certain samples, whether pre-chemo or pre-interventions or pre-surgical interventions. After the surgical interventions, we also can collect some certain tissues that ultimately will be resected during the surgery, and even after during the follow-up period, once they start receiving certain therapy towards dictating the responsiveness towards these therapies, towards identifying certain targeted therapies, identifying certain biomarkers during their journey. All of these samples could be collected by the biobanks. Again, we're not just collecting blood. Biobanks usually they collect huge amount of spectrum of samples. We're talking about blood, we're talking about serum, we're talking about tissue. So any type of samples that you might think of ultimately can be collected under biobanks. Not only samples, but they have also been connected with huge amount of information. We're talking about pathological reports, diagnostic, molecular classifications, treatment informations, diagnostic data, objective, subjective, self-reported data. All of these collectively can be stored in the hub of the biobanks. Ultimately, they get stored in something that is called the LIMS system, or Laboratory Information Management System. This is just to give you an example of how the interface of the LIMS system usually looks like. We're talking about, again, a huge amount of information stored under one auspices. Now, in terms of the classification for biobanks, we have different classifications for biobanks. Certain biobanks are, designed to be population-based biobanks, and some of them are actually disease-oriented. They focus on a designated and a specific disease state. In our case, in the Saudi Biobank, we have a population-based biobank, and we have within the population base a sub-embedded cohort of certain disease states that are directly linked to the major and prevalent disease states that are quite prevalent in Saudi Arabia. So for example, when I start talking about the breakdown, within the breakdown itself, we have smaller sub-embedded cohort, hypertensive patients, diabetic patients, certain individuals who have certain tumor cases. Some other biobanks needs to be designed towards their objective. So for example, some biobanks will be designed just to support the purposes of clinical trials. Some of them will be designed just to support basic research or population-based projects. So it comes from the major aspirations coming from the leadership towards establishing these biobanks. And by the way, it's not cheap to design or to establish a biobank. It takes a village to raise a child in these types of businesses. Now, when you take a look at the prevalent or the uptake or the number of publication on biobanks, you can see that there's a uptrending in the scope of publications when it comes to biobank. And for the most part, the major field that is taking advantage of the field of biobank is basically the cancer field. And we can see the huge evolution in the cancer field. Every day we have a new molecule that hits the door that has to be tested within huge sample populations. We need to validate some of their effectiveness in our real-world informations. This is just to give you an illustration of the number of publications that have utilized the UK Biobank data. And you guys can see that on average, currently, they're averaging 1,400 publications per year coming from one resource, which is the UK Biobank. However, when you delve and you dig deeper in these biobanks, you will realize that the ancestries are, quite skewed towards certain population. So we currently need more diverse biobanks to improve the behavioral genetics in our region. This is just to give you an illustration. You guys can see at the top left side and at the top right sides, the UK and the US representations. And you guys can see in the light blue, for the most part, the population that they have under their biobanks are basically mimicking the general population or the general census from their own country, which basically come from non-Hispanic white population or European ancestries. Can we extrapolate the information that usually gets to stem from these biobanks or from their own research towards our population in our region? Well, technically, to a certain extent, we utilize some of their guidelines. So technically, we're generalizing some of their information. However, from, if you go back to 101 biostats, basically you need to have a representative sample from your own country that ultimately you can generalize certain information. So basically, there's a big push towards establishing biobank in our region, especially in Saudi Arabia. And as you guys can see in the lower graph, you guys can see that over the years, over the past 3 to 4 decades, we started to see a shift towards the geographic representation or the ancestries. At the bottom, basically, we can see European and North American ancestries. And once we started to go to the 2000s, we started to see non-European and non-North American ancestries. We started to see more of an Asian ancestries and some of the Middle Eastern and Asia-Pacific ancestries. Now, this is one thing. We have to have clear representations of the population that we have in hand in our region. And the other thing, we're major assets to the scientists. And when you ask the scientists, why do you need a biobank? One of the studies evaluated this qualitatively. And for the most part, these were the major themes that stemmed from this particular study. Scientists were saying we need a strategy that are aligned with our research needs. We have to have an adequate consent modalities. We have to have huge amounts of participants and clinical data in order for us to generalize our informations, validate our informations. So throughout the whole journey of collecting the sample all the way to the processing and distribution of these samples, there are certain hiccups and some bumpy roads that comes throughout the pathway for the scientists. And for the most part, biobanks are the major venue to overcome all of these obstacles. And not to mention, we have a rising prevalence of certain disease states in our region. So all of these things collectively necessitate the initiation or the launch of certain biobanks in our region. So I hope I was able to give you a certain perspective of why do we need biobanks. And at the bottom line, they're actually profitable businesses. If you look at certain biobanks, they generate revenues more than our own country. So if you go to the UK biobank, for example, the major revenue that they were able to generate over the past 10 to 15 years was basically more of our total GDP here in Saudi Arabia. So it's extremely profitable. Overall, the global biobanking market was at close to $60 billion annually, and it's expected to continue to grow at a 6.3 cumulative annual growth rate to reach close to $78 billion annually. So it's extremely profitable business if you think about it. So again, I hope I was able to summarize the first portion of my presentation for you about the biobanks, the objectives, the way they work, types of samples, and so on and so forth. And with that, I'll move towards the second part of my presentation, which is basically to summarize some of the Saudi Biobank objectives and future directions. So just to give you a historical background, the Saudi Biobank was established as one of the initiatives of the Vision 2030. It was established in 2016, and it became operational in 2017, and it went live in 2018. It's considered one of the major components of the King Abdullah International Medical Research Center. So we're pooling in every single department that you can see on this slide. We're intersecting with the other departments that are under KMARC, but for the most part, we're also integrated with major aspirations of the Blood and Cancer Research Department in KMARC. We're serving these 6 purposes for the most part. We're talking about blood and cancer, diabetes and metabolic disorders, cardiovascular diseases, rare and genetic diseases, neuroscience, and infectious disease, besides our population-based cohort. So as I mentioned at the beginning, we are disease-specific and a population-based biobank. So these are the 6 major disease states that are currently under our study biobank. Our mission is basically to provide innovative biobanking services and biospecimen collection that ultimately will foster biomedical research. And our vision is to be a leading center of excellence in providing scientific resource for conducting cutting-edge, intelligent medical researches to advance the healthcare quality. In terms of our space, I invite each one of you to have a visit to our biobank. We have a huge building that's considered one of the largest biobank that currently exists globally, and we can accommodate more than 10 million samples at any given point. Now, our strategic goals is basically to become a national and global hub for biobanking and promoting high standard biomedical and clinical research, and to promote R&D and innovation, innovative collaboration among researchers, especially in the precision medicine and oncology fields. When you talk about the competitive advantage of the Saudi Biobank compared to the other biobanks that are currently located in the region, we are rooted within an established healthcare system. So we're part of King Abdulaziz Medical City or the National Guard Health Affair. We're also connected to a research center and ultimately also connected to a medical university or healthcare university. And all of these, facilities are connected in one electronic health record system. So all of the patients that we enroll, all of the participants that are currently within the Saudi Biobank are connected in one electronic health record system. So I can go back retrospectively or prospectively to look at their historical risk factors or index events and correlate them with any future events that might be take place in the future. When you look at the breakdown or our structures, we're basically a part of us are scientist team, recruitment team, lab team, tissue team, and data team. And for the most part, the ones that are within red squares are actually those individuals who are specialized in cancer research. So our scientist team, we have two scientists who are actually specialized in cancer research. One of them is in oral cancer biology, and the other one in breast cancer. And our tissue unit team is basically specialized in cancer research. So I'd love to invite any of the scientists who are listening to us or tuning with us to join us if they have any aspirations to conduct any of their ongoing research or future research under the Saudi Biobank. We're also connected with a massive network of experts who provide their expertise with us. Some of them coming from cancer centers such as Cedars-Sinai Medical Center, and some of them are coming from the WHO, and some of them are expert from certain notable biobanks. In terms of the policies and of the Saudi Biobank, we have huge amount of policies under in-house, and for the most part, we have a designated policies that are mainly specialized or mainly tackling the component of oncology, mainly in the tissue staining, tissue preparation, and how we can, embed certain tissues. How do we preserve them? How do we store them? How do we process them? And how do we utilize them in the future? So again, it's a very controlled area here in the Saudi Biobank, in which every single step that that gets to be undertaken under the Saudi Biobank has to be tracked in a certain way and has to be replicated in a manner that it's reproducible. So our workflow, we have two types of workflow. We have our own Saudi Biobank for anyone who's interested to join our forces or to utilize our infrastructure. We have our Saudi Biobank project, which is a population-based cohort and sub-embedded certain disease states, sub-embedded disease state, and we deliver biobank services. So let's say you are a scientist, you want to conduct a study on a certain patient population. We're talking about certain tumor, we're talking about certain staging. We have the adequate manpower, we have the adequate resources that ultimately could help you in recruiting those participants and ultimately store these samples and ultimately be of huge use for you as a scientist and for the other scientists at large. Usually, we start with consenting the patients and the patient undergo an extensive questionnaire in which it takes into consideration every single aspect that ultimately doesn't get to be pulled in their electronic health record system. We're talking about nutritional aspect, socioeconomical, marital status, insurance, and so on and so forth. And we all know from the aspect of the epigenetic, all of these components are extremely enriched in any study in epigenetics. If anybody is asking how do they access any of our data, whenever you file a request, ultimately we do our homework and see if we have the samples that you're looking for in hand. And if yes, it goes to a designated steering committee for approval and for voting. If they approved your request, ultimately we will be able to release these samples to your aspirations. We also invest extensively in cancer competencies and in our employee competencies, especially in cancer and tissue biobanking. We have an ongoing and an annual training programs in biobanking. One of them advanced course and one of them is an introductory, but all of the manpower who are currently working under the Saudi Biobank has to go under these training program. It's a mandatory requirement to work under the Saudi Biobank. And thankfully, with all of these things under the the solid infrastructure that I just mentioned, we were able to secure the first ISO accreditation for biobanking in our region. So the Saudi Biobank, it has that gold standard, stamp for any research ultimately, that all of the samples that gets to be utilized under or gets to be stored under the Saudi Biobank are ultimately coming from a biobank that is ISO accredited. And this is huge for any research. Whenever you try to submit any manuscript, they will ask you for the SOPs, they will ask you for the way that the samples were collected and how they were processed, and so on and so forth. In terms of the numbers, just to give you a certain perspective about the current numbers that we have, just last year we were able to recruit 6,365 participants, and again, this is a population-based cohort. We're averaging about 5 to 21 participants per day in terms of our recruitment, and this is just last year. And collectively, we're able to collect about 57. Now we're averaging 60K participants who are under the Saudi Biobank. Ultimately, there is a major objective or major goal in the near future to conduct similar to what the UK Biobank did, which is basically to conduct the Saudi Biobank genome study and ultimately get to pull the output of that study in the Saudi Genome Project, so that we can have an extrapolatable data that represent the general population. In terms of the cancer or the tissue biobank, as I mentioned, we have population-based and a disease-specific, and we have our tissue or cancer biobank that's mainly tissue biobank. In terms of the number of cases that we had last year, it's close to 280, and the number of blocks was about 400. And collectively, ever since we established the tissue biobank, we have more than 1,200 of cases, and in terms of the blocks, we have more than 2,000 blocks. And for the most part, 60% of them are breast cancer, and about 40% of them are colorectal cancers. We have major aspirations to expand the type of tumors that we get to collect. However, as we all know, there is a certain reluctancy in terms of when do we collect the samples, at what what stage do we collect these types of tissues. And now we're in a big negotiations with the surgical team and our oncologists and hematologists to have a streamlined process for us to streamline the process of collecting these types of samples. But when we started this project initially, we wanted just to test the water. We wanted to see if we were able to do this type of project under the Saudi Biobank. It was a huge success, to be honest. These types of tissues are extremely precious. If you're in this field, you realize that you can use them throughout the whole journey of the patients. You're talking about for biomarker identification, target identification, staging, and so on and so forth. We have also two projects under the Saudi Biobank, and they're owned by the Saudi Biobank. One of them consists of establishing the CML registry under the Saudi Biobank, and the other one is the LPD registry under the Saudi Biobank. So both of these two registries are currently located. They have different PI, but both of them, they are located in the Saudi Biobank, and we're welcoming any project that would like to utilize these samples. Currently, we have more than 20 projects at the moment, and for the most part, 50% of them are in precision oncology or in the oncology field. And we were also honored to have a visit and an agreement with the international agency just recently with some of our scientists who are among the audience today. We're talking about Dr. Nadine, Dr. Abdul Manam, Dr. Dalal from KMark. They had a fruitful journey to IRIC, and some of their projects will ultimately be launched soon and will be delivered with the utilization of the assistance of the Saudi Biobank resources. We also have a backup plan. Biobank samples are extremely precious. At any given point, if God forbidden, the electricity went down, we have a contingency plan in which we can transfer all of these samples ultimately to the public health authority. And we have numerous future projects that are coming along the way. We have a new site that will be launched soon in the chronic disease management, and one new cohort in women in cancer that ultimately will be launched soon, inshallah. And we have a major goal to work with Evolution Foundation in the longevity field. And as I mentioned at the beginning, we have a major project that's coming soon, which is the Saudi Biobank Genome Project with Illumina, and some of the other projects will be with the World Health Organization under the International Agency for Research in Cancer. Finally, I would like to acknowledge certain individuals who, paved the way for this project to see the light. Basically, His Excellency Professor Bandar Ganawi, the CEO of the Ministry of National Guard and President of King Saud bin Abdulaziz University for Health Sciences, as well as Dr. Ahmed Al-Askar, the Executive Director of KMAR, for their numerous effort towards establishing this national project, as well as my team at the Saudi Biobank. Despite the fact that we have 99% of female. Again, I would love to thank them, despite the fact that they drive me crazy, not that because that they're female. I would like to sincerely thank each one of them. They are huge and major assets to the country. Each one of them is trained in biobank like no other discipline. With that, this is the email for the Saudi Biobank. If you are a scientist or you are a stakeholder who would like to collaborate with us under the Biobank, we would love to for you to reach out, and looking forward for the Q&A session. Thank you so much, everyone.
Thank you so much, Dr. Hisham. This is a very great presentation. I would like to present our next speaker, Dr. Dalal Al-Daghaither. She's an assistant professor at King Saud bin Abdulaziz University for Health Sciences in Riyadh.
Hello, everyone. My name is Dr. Dalal Al-Daghaither. I'll be talking about cancer biomarkers, and I'll be giving a general talk. I'm an assistant professor at KSAUHS. We'll get started. So I'm going to start with the clear definition of what are biomarkers. So biomarkers in general are biological molecules in blood, in other bodily fluids, and in tissues. They usually indicate a normal process, an abnormal process, how a person can respond to a certain treatment or not. More recently, biomarkers have been essential for precision oncology in guiding diagnosis, prognosis, as well as treatment decisions in general. So why are biomarkers important? First of all, they help personalize therapy. Therapy is no longer a one-size-fits-all approach. They tailor the treatment approaches depending on how the patient and their profile, their molecular profile. Also, they minimize ineffective treatments. So by knowing the molecular profile of patients, we know what they respond to, what they don't, and we reduce unnecessary side effects of these patients. Next, they improve survival. So by knowing what the molecular phenotype is of that patient, we know what drug or what treatment to give them. It gives us a better outcome through this procedure. And finally, we're able to monitor the disease. We track the minimum residual disease as well as relapse before imaging can even track them. So the methods for biomarker testing is either tissue biopsy, a liquid biopsy, IHC, or NGS. Tissue biopsy remains the gold standard because from a simple tissue, we can do histological, we can do IHC, as well as the molecular evaluation of the sample. However, tissue biopsy is still very invasive. not all patients we can get a tissue biopsy from all the patients, especially later on in later stages. It's very hard to get that tissue biopsy. Second, we have a liquid biopsy. It's minimally invasive. It's useful to detect and for monitoring and detecting resistant mutations. However, this is very limited by sensitivity of liquid biopsy. Next, we have IHC. IHC is a very useful tool. It's in most labs. It detects protein expression, HER2, PD-L1, and it's widely available and it's cost-effective nationwide. Any lab will have IHC in it. Next generation sequencing, it has become very essential, especially in the era of precision medicine. However, IHC is very expensive. It gives us a comprehensive genomic profile. However, it detects point mutations, fusions, copy number variation. Again, it's not everywhere, and not every lab can have NGS worldwide. When we categorize cancer biomarkers, they can be diagnostic, where they detect cancer, like PSA in prostate cancer, prognostic, where they indicate the outcome, predictive, where they forecast the treatment response, or monitoring, where they track the progression of the cancer, as we see in ctDNA. I'll give you a brief overview of colorectal cancer, because I'm sure it's going to be covered in the colorectal sessions as well as lung cancer and breast cancer sessions. KRAS mutations and NRAS mutations, they predict the resistance to anti-EGFR therapy. They're widely used in all patients. Next, we have BRAF V600E mutations. They're associated with poor prognosis, and it's important to note that KRAS and BRAF are mutually exclusive. So if we give the patient an inhibitor of a BRAF and anti-EGFR therapy, they usually have a better prognosis. HER2 amplification, although it's very rare in colorectal cancers, it's seen, especially in metastatic colorectal cancer. If there is HER2 amplifications, usually trastuzumab works for these patients. MSI high and DMMR, they predict response to immunotherapy, as Dr. Faiza highlighted in more detail earlier session. Lung cancer biomarkers, EGFR, ALK, and ROS1, they are Q mutations for all the target therapy. PD-L1 determines whether a patient can get immunotherapy or not. The new upcoming targets, such as RET, MET exon 14, exon skipping, KRAS G12C, these are all emerging biomarkers in lung cancer, and they are FDA approved. Also, we have ctDNA, which detects the resistance in MRD. When it comes to biomarkers of breast cancer, we have the ER, PR, HER2. These define what a breast cancer, different types of breast cancer or subtypes of breast cancer. We have oncotype and MammaPrint, and these are immunogenomic assays. BRCA1 and BRCA2 are biomarkers that give us an indication about the hereditary status of this breast cancer, and PK3CA gives us an indication whether this patient can get PIK3 inhibitors or not. Next, we have the pan-cancer biomarkers. These are biomarkers that are found in most cancers. As you can see from my slide, the first thing I have is molecular classification, the top, is because we want to shift all oncological research, oncology from organ-based approach to a molecular approach. Okay, because each molecular phenotype of a cancer is different. So MSI high DMMR, it's already approved across solid tumors, tumor burden, TMB, a high burden that benefits immunotherapy, and NTRK fusions, although rare, it is targetable across multiple cancers. This is a list of different biomarkers. As you can see, HER2 and BRCA1 are both predictive and prognostic. The rest are mostly predictive biomarkers. So what are the emerging technologies in biomarkers? We have liquid biopsies, such as ctDNA, as well as exosomes, single RNA sequences, which maps out the intramural diversity of the tumor. Also, artificial intelligence. The AI is gaining traction every day. It enhances biomarker discovery as well as image analysis. I'm not sure how AI is applicable, but exact details, but AI is gaining more and more traction. Multi-omics. So when we have the cancer, we look at it genomically, usually. But if we add to the genomic profile, the transcriptomics, proteomics, metabolomics, as well as epigenomics, we can actually look at the cancer more in a better way and more thoroughly. If we look at the clinical integration of biomarkers, it can guide the treatment decision as the first line of therapy. Usually, patients previously, they did not know what they were getting, but if the oncologist has the biomarkers, it can guide that first line of therapy. Also, it helps us stratify the patients. PD-1 patients, PD-1 negative patients. Also, disease monitoring, early detection, as well as resistant tracking. Also, tumor boards. Tumor boards, we have scientists, we have oncologists, we have pathologists, all coming together and discussing this patient's profile, this patient, and it leads to individualized patient care. What are the challenges and limitations? There are multiple challenges and limitations with biomarkers, as you guys might know. First of all, the false positives and false negatives. Increasingly, we have technical variability in the assays that are being done. Also, we don't know when the samples are taken from the patients, as well as the quality and timing. These all influence the results. The tumor heterogeneity also affects it greatly. Single-site biopsies may not reflect the full tumor profile. Also, limited accessibility as well as the cost. NGS is not very cheap. It's very costly and not available in all clinical settings. Also, there's high cost and lack of reimbursements in people who have insurances. Finally, is interpretation complexity. Some biomarkers have an unclear clinical relevance. Guidelines and thresholds, they differ. And depending on the person reading the profile, the interpretation differs. Future directions, we want universal access, so comprehensive testing for all, a pan-cancer classification beyond this organ-specific approach, real-time diagnostic, so when we are in the clinic, we can actually, at the point of care, we can test the patient. And finally, AI decision support. We will use AI, give it the full molecular profile of multiple tumors to help guide us and guide the treatment that we have. Thank you.
Thank you, Dr. Dalal, for the enlightening talk, and stay tuned with us for questions after the end of the session. And it's my pleasure to introduce Dr. Kanaan Al-Shambri. Dr. Kanaan I would just summarize that he is leading many initiatives at the national level when it comes to oncology, whether being the director of the MENA and CCN in the region, or leading many research groups at the basic science level as well as the clinical practice level. He will be actually talking today about very, very interesting topic that we have in oncology, which is the development of tumor agnostic approach in oncology.
Thank you, Marwan. Assalamu alaikum. So I'm happy to be talking about this exciting topic of tumor agnostic drug approvals, which I think is synonymous with any precision oncology conference. So this is going to be the overview of my talk. I'll define what tumor-agnostic approvals are. I'll briefly go over the drug development with real examples. I'll talk about current FDA tumor-agnostic approvals, then I'll conclude. So the NCI definition of tumor-agnostic therapy is basically using the same drug to treat all cancer types, regardless of their histology, that have a certain genetic mutation or a biomarker that is targeted by the drug. It is a type of targeted therapy and hence the tissue-agnostic therapy. So historically, and I think until now, we are treating cancers based on their anatomical location, meaning the chemotherapy or certain targeted therapies that are used for colon cancer are not really used for lung cancer and so forth. However, there is a paradigm shift now, and we are moving towards tumor-agnostic therapies, and hence, if your patient has a BRAF V600E mutation, whether they have a colon cancer, lung cancer, breast cancer, or other cancers, we would be treating them with anti-BRAF therapies, and this is what treating using tumor-agnostic therapies is all about. So basket trials have been developed specifically in precision oncology, and it is when you match patients according to their molecular profile, regardless of their histological profile, and this is basically a result of their tumor genome sequencing. So we depend on their molecular testing and molecular aberrations, and not the histotype or the histology for dictating sensitivity to either targeted therapies or immune checkpoint inhibitors. And this is basically what genotype-driven clinical trials or precision oncology trials is all about. This slide dates back to early 2023, and these are the FDA-approved targeted therapies in oncology. So there are not many. We have pembrolizumab, dostarlimab for deficient MMR pan tumors. For microsatellite high tumors, we have pembrolizumab, TMB high, again pembrolizumab. For BRAF V600E mutations, we have dabrafenib and trametinib. RET fusion, selpercatinib. NTRK, we have two agents, which I'm going to be talking about, larotrectinib and entrectinib. And I think in mid or late 2023, trastuzumab deruxtecan was also FDA approved for pan tumors or HER2 amplified tumors. So how did the TRK story start? So we know that there are TRK expression or receptors. There's TRAC A, B, and C. They are responsible for pain, thermoregulation, movement, memory, and proprioception. Basically, they have been studied and were basically identified if they have a fusion to be an oncogenic fusion, and these affect a diverse pediatric and adult cancers. Now, the prevalence of this fusion is quite variable. In general, they are extremely rare. We're talking about probably a 0.1 to a 0.5% in all types of tumors. If we go to pediatric infantile fibrosarcoma, a rare type of sarcoma that is chemorefractory, we're talking about a prevalence of more than 75%. Secretory breast carcinoma, certain thyroid cancers, we're talking about a range of 25 to 50%. Sarcomas in general are enriched here in this TRK fusion tumors. So larotrectinib as well as entrectinib are both potent small molecule inhibitors that target TRAC A, B, and C. They are highly selective with minimal interaction with other kinase or non-kinase targets. They do or they have demonstrated activity in central nervous system disease. This is really important as some of these TRAC fusion positive tumors are gliomas. Liquid formulation allows dosing of children. Remember, these are approved in, or they are enriched in pediatric populations. And larotrectinib is active against TRK fusion cancers and have demonstrated durable responses. Now, in clinical trials, when we talk about phase 1 clinical trials, we usually test for safety. Usually, efficacy testing is not done in phase 1 clinical trials. However, in these rare receptors or rare biomarkers, when usually the design is a seamless design, they usually escalate from phase 1 into a seamless phase 1/2 clinical trial. And this is exactly what happened with the NTRK fusion inhibitors, where the early phase 1 clinical trial included 10, then this was expanded into a seamless phase 1/2 trial with more patients. And then another big phase 2 clinical trial that included more than 100 patients basically established the safety of this drug plus the efficacy. Now, this is what we call a waterfall plot of larotrectinib. As you can see, the columns have different colors indicating different types of tumors. So we have infantile fibrosarcoma, adult soft tissue sarcoma, melanoma, thyroid cancer, colon cancer, cholangiocarcinoma, and this showed an objective response rate of more than 80%. And based on just this waterfall plot, a US FDA approval occurred for this agent, as well as entrectinib for NTRK fusion positive tumors. Now, the RET story, the RET receptor is a well-known receptor. It has been studied in different forms, and once it is activated, it is known to be an oncogenic driver. So it started probably in the mid-80s when the RET oncogene was discovered in thyroid cancer as well as in lung cancer. Around 10 or 7 years ago, early phase clinical trials again for RET inhibitors were done. And more recently, a pan-tumor RET inhibitor trial occurred. So RET fusions basically transform primary cells such as fibroblasts or thyrocytes in the thyroid in vitro and in vivo. They activate downstream signaling pathways. They promote cell proliferation, and hence they are oncogenic. They occur basically in a mutually exclusive fashion in many cancers with other biomarkers. This is the waterfall plot as well as the swimmer's plot for an agent called selpercatinib. It is a pan-RET fusion inhibitor. And as you can see, these columns and rows have different colors indicating different types of tumors that this RET inhibitor was given to. And again, durable responses with excellent objective response rate. And hence, there was an FDA approval for this agent. Now, the RAS-RAF-MEK-ERK pathway is a well-known pathway in colorectal cancers. We call it the MAPK pathway. Alterations in BRAF that lies downstream of RAS basically affects this signaling pathway and activates MEK in the MAP kinase signaling cascades. BRAF V600E mutations occur in about 7 to 15% of all types of cancers. They are quite prevalent in malignant melanoma. In fact, the prevalence of BRAF V600E mutations in melanoma is about 50%. They are less common in other cancers. However, they are present in cancers such as anaplastic thyroid cancer, biliary tract cancers, GIST, low-grade gliomas, high-grade gliomas, as well as others. And hence the ROAR study design, which is a large phase 2 basket trial that basically gave a BRAF inhibitor plus a MEK inhibitor to differing types of tumors, such as anaplastic thyroid cancer with BRAF V600E mutations, biliary tract cancers, different gliomas, colon cancer, as well as others. They gave them the dabrafenib and trametinib, so a BRAF and a MEK inhibitor. So within the same pathway inhibition. And this was the objective response rate. Now, this study was led by one of the precision oncology pioneers, Vivek Subbaiah. This was published in 2022, and basically objective response rates were ranging between 30 to 50%, depending on the histopathology. Now, BRAF V600E inhibition is definitely tumor agnostic. This was supported by the large NCI match study of 2021. Basically, colorectal cancer was a slightly different story, as we need to give it with an EGFR monoclonal antibody plus chemotherapy. And this resulted in a recent FDA approval for encorafenib, cetuximab, and FOLFOX in the first-line setting. There have been many case reports that have been published on different types of tumors with BRAF V600E mutations that have been given dabrafenib and trametinib, and hence there was also pediatric data available in the literature, and all of this information led to a US FDA approval for dabrafenib and trametinib for pan tumors. Now, probably the latest target that will most likely gain a pan tumor or a tumor agnostic approval would be FGFR inhibitors. So FGFR mutations and fusions do disrupt signaling and do drive oncogenesis. They are probably more common in biliary tract cancers. They're prevalent in about 10%. They are also prevalent in different types of cancers, such as gliomas in 2%, endometrial cancer in about 2%, urothelial carcinoma in about 25%, as well as others. The Ragnar clinical trial basically is the largest tumor agnostic trial reported to date. So they did 3 interim analyses of 200 patients. The third interim analysis, which I'm going to report here, which basically gave an FGFR inhibitor to different types of tumors with FGFR, either mutation or fusion. Now, the 180 patients that were enrolled in this phase 2 clinical trial ranged from gliomas, cholangiocarcinomas, soft tissue sarcoma, non-small cell lung cancer, as well as pancreatic cancer and other cancers. This is the waterfall plot. Again, impressive data providing that this is in pan tumors or different histologies. And the results was that 66.3% of patients had a reduction in their tumor burden. So now this is the objective response rate. So the clinical or the objective response rate was about 50 or 26%. And the duration of response was 7.1 months. Now these are heavily pretreated patients. Overall survival was 10.9 months. So most likely this will be the upcoming tumor agnostic approval, which is going to be an FGFR inhibition. So take-home message from my talk: in precision oncology, tumor agnostic therapies do play an important role in the new era of precision oncology and personalized healthcare, challenging the existing diagnostic and value assessment frameworks. However, funding arrangements for innovative and personalized medicine are not really universally in place, limiting patient access and eligibility of treatment. We know that there is a lack of early phase clinical trials in the region here, and hopefully this will change. And a common understanding and endorsement of tumor agnostic therapies from clinical and patient representatives is going to be crucial to develop the knowledge base and raise awareness of these clinical trials as well as these therapies. And thank you for listening.
May the speakers just come to the front, actually. I will have some discussion. I will start maybe from 3 questions that have been in my mind actually since you guys presented. So as the Dr. Hisham, you talked about the biobank and all the samples that we have. Congratulations, a huge number of samples, and hopefully this will lead to some great work and data actually from our country. One thing that just came across my mind, do we have microbiome biobank or no?
Oh, yeah.
We do?
Yes.
Okay.
Are you working on that?
I hope so.
So basically, 2 entities currently are championing the Saudi microbiome project. The first entity is KAUST, and the second one is KMARC. With the help of Dr. Mohammed Boussaid, who is the chairperson of the infectious disease department, just recently we established the Saudi Biobank microbiome project. So for any microbiome projects, as you know, you need healthy individuals for the most part, and you have to have a constellation of different types of samples. So we tackled the employee clinics, the newly hired employees, since those types of individuals usually, hit the door or get hired as health individuals until their boss, get them to be deceased.
And the follow-up questions with the samples that you mentioned, do we have sequential samples for one patient?
Yes,
like people on treatment?
So we started to have certain sequential group of participants in which we started to collect certain follow-up samples. Usually we track the patient throughout their journey, and we see whenever their upcoming clinical encounters and try to approach to them. But to be honest with you, the receptivity rates from the participants is not that high. For the most part, I would say it's about 40%. So out of 10 participants who were historically recruited, 4 out of them, they decide to be re-recruited and they donate blood samples to the biobank.
And this is, I promise, my last one. So are we, the prices and the cost, is it being driven down now when in terms of the collection and to do all the analysis? Because if the price goes down, it means we can.
What do you mean the price? What do you mean?
The whole
cost of it? Well, thankfully, we are under a government entity so far.
Just to include more samples from everywhere.
Yeah. And, there was a plan actually to expand our work with our neighboring biobanks. However, we decided not to move forward with that project just because that we needed to have a homogeneous sample population under the Ministry of National Guard for us to be able to re-recruit them again.
We're all homogeneous here, so.
Yeah. I mean, in terms of
I'm not talking about the different Caucasian.
Or no. What I was trying to say, basically, individuals who are connected in one electronic system. Yeah, basically.
Yeah. So, Dr. Rehan.
Thank you so much. I have also one question for you, Dr. Hisham. I think it was very interesting to know that because it's very expensive to store all the samples and the data, and you mentioned that there is a financial benefit. So I expected that it would be costly instead of providing benefits. So can you please tell us from where this the financial benefit come from? Like in general, not only in imaging,
So if you think about it, the UK Biobank is 70% funded by pharma companies. 70% from the resource that gets to be allocated to the UK Biobank are coming from pharma industry. And the main reason is basically I can provide you or can grant you an early access to the samples. So let's say you've discovered a new molecule and you want to test it in a group of participants who have, a special characteristics or underlying disease conditions. Usually, the early access for the data and the samples comes from the UK Biobank in this case. So for the most part, the revenue generation from biobank comes from industry, biotech, and also from other companies or other industry that are not benefiting from the samples itself, but they're benefiting from the storing capabilities. So for example, we have multiple companies that they design these huge, like Boeing in terms of, the Airbus and these types of things. We're not talking about simple freezing resources or storing capabilities. We're talking about massive storing capabilities. So I would say for the most part, the major resource of profit and revenue for any biobanks are coming from pharma and biotech companies for the most part.
I don't know, but I'm imagining that one day that we'll have just a kit with us and we just check ourselves and we have everything send and analyze.
Yes.
Just so maybe hopefully one day. If we have any, there are questions in the system. I'll open it up here. But if we have any question from the audience here.
So I have a question for Dr. Kanaan, if I may. Yeah. Doctor, is there any possibility to engage the biobank with our clinical practice where we can get samples from all newcomers as cancer patients? So we send some for pathology testing and the other for biobanking. So we have a prospective cohort ongoing data collection process. Is that possible? Do you have any plans?
good timing for the question since we have the biobank head here. But do I have any plans? I don't. But is it possible? It's definitely possible. And I think it will, just like Dr. Hisham said, it will enrich basically the tumor samples or the biobank samplings of tumor and hopefully enrich the area for upcoming clinical trials. And I highly recommend or suggest that we reach out to biopharma companies, telling them that, you know, we have an abundance of cancer cases. And probably one of the things that we should probably tackle would be hepatocellular carcinoma, since it's prevalent in our population. It is not routinely biopsied, and it's not really a disease of the West. It's mainly a disease of the East. And this is probably something that we can discuss later.
Yeah. I wish the technology just become cheaper one day. So just to give you an idea that it's very expensive to do just a simple NGS, and still, if you need a good quality one, AI integrated, etc., it's very costly. And this is insurance approves it, but still, it's part of the whole cost.
But I think now there are local companies that are actually doing NGS, which is really driving the cost down. And what quality testing do they have? It's very variable, and with lower costs, you don't really expect a higher quality. But I know there's a huge variability now of NGS capabilities that are done in-house within the kingdom in private labs. So I think it will drive the cost down, but I hope that the quality remains good.
But just one caveat, and when it comes to that, is just most of the time the whole lab is accredited, but the test kit is not accredited. So we end up into that disclaimer at the end of the report that you cannot use that for therapeutic purposes, which is a problem for us when we do it. So, but I think we have any question, any comment? All right. So I think we can conclude. Thank you. Or you have? Yeah, one question. Okay.
So I saw in most of the clinical trials, a complete response is still like 3 patients, 5 patients. So do you imagine, or do you think after 10 years, 5 years, with better understanding of the cancer biology, we will be able to get like 50%, like in immunotherapy? I think in immunotherapy, the complete response is a bit higher. So it's either complete response in most cases or no response.
And with targeted therapies, I think it's a lot more complex than we think it is. And when you block a pathway, and I think we've seen this in our molecular tumor board, a different pathway emerges as a resistance mechanism, and hence, you know, cancer propagates. So I think with targeted therapies, it's not just like immunotherapy. With immunotherapies, you see durable responses, complete responses, more than targeted therapies. I think with better understanding of cancer genome, you know, with the development of better next generation sequencing, specifically when we do temporal data. So when we do NGS in different time points of the cancer, we see how the genome changes. I think this is when we'll gain a better understanding of the behavior of the cancer genome, and hence we'll be able to target it in a more efficacious manner, and hence hopefully this will result in better outcomes, whether it's complete response or durable responses.
All right. Thank you so much. Thank you, everyone, for all the speakers and the attendees. And we have 20 minutes break, and then we will resume our next session. Thank you so much.
Thank you all for attending this day. Please be informed that we'll be going on a short break for 20 minutes and we will be back at 4 p.m. Thank you all. For inquiries, استفسارات about SMEs, please keep an eye on the chat box. We'll be sending the attendees collection forms in the chat box. Thank you all. See you after 20 minutes. Assalamu alaikum.
السلام عليكم.
Assalamu alaikum, Doctora. We are currently on a break. We'll be back at 4 p.m. exactly. Please be sure that please be reminded that we are live now. Thank you very much.
Thank you.
Dear values attended, Assalamu alaikum. Dear values attendees, please be informed that we will be sharing the registration link in the chat. So please stop sending unrelated information in the Q&A box. Please also be reminded that we'll be sending two links, one at the beginning of session 2, and the last one will be at the end of session 2 to collect attendance. And you need to fill these forms. Also, I'd like to remind you that now we have an app where you can download it in your mobile, and we will be notifying you about the upcoming continuous medical educations event, and you can register through that app. Feel free to download it, and we are happy to have you all here today. So we'll be back in 6 minutes. Thank you all. Have a nice day.
السلام عليكم دكتور محمد، كيف حالك؟ Yes. Shall we start?
Go ahead.
Sure. Okay. Assalamu alaikum, everyone. I would like to thank the organizing committee for this kind invitation. Now we will start the thoracic and breast oncology, and I will be moderating this session with Dr. Mohammed Al-Ghamdi. Our first speaker is Dr. Alauddin Youssef. He's a consultant medical oncology at King Abdulaziz Medical City in Riyadh, and he will enlighten us about targeted therapy in advanced breast cancer. Dr. Alauddin.
Good afternoon, everyone. Assalamu alaikum wa rahmatullah. I'd like to take this opportunity to thank the organizing committee for inviting me to this esteemed meeting. My name is Ala Yusuf. I'm a medical oncologist in MNGHA. I'm going to speak about advanced breast cancer. As we know, advanced breast cancer affecting millions of women every year. And it impacts the lives of those women, and it's particularly the one with the estrogen positive disease. Endocrine therapy has been the foundation treatment of this. Sorry, can we go back? Thank you. So endocrine therapy has been the foundation treatment of this type of cancer, and it's positively impacting their outcome and survival. However, development resistance has become like a hurdle on this treatment. In light of this challenges, targeted therapy has become a very important issue. Here we can This is a roadmap of personalized therapy for breast cancer. And in 1977, we have the tamoxifen, which is the first targeted therapy, and even in the whole medical oncology. In 1997, we see in the aromatase inhibitors like letrozole, anastrozole, and exemestane. In 2002, we have the emergence of selective estrogen degraded fulvestrant. And in 2015, we have the approval of CDK inhibitors. And we have 3 agents, which is palbociclib and ribociclib and abemaciclib in combination of aromatase inhibitors. And in the last couple of years, we have the approval of PI3 kinase inhibitors and mTOR inhibitors and AKT inhibitors. And I put a special star on those because it's the only one that uses NGS to directed therapy. So it all depends on the sensitivity of endocrine therapy. You can have highly sensitive disease, as you can get de novo metastatic with very long disease-free interval, almost 15 years. And then we have likely sensitive if you have long disease-free interval, like around 2 years, and then after completion of adjuvant endocrine therapy. And primarily, they are like bone disease and mild soft tissue disease. And then you have moderate sensitive disease, which is a disease-free interval about 6 months after completion of adjuvant endocrine therapy. And primarily, they are bone and visual disease. And then you have moderately resistant disease where they progress within the duration of the adjuvant endocrine therapy. And you have then a likely resistance, which they are progressed in less than the first year of adjuvant endocrine therapy. This is I'm going to focus on this incorporation of CDK inhibitors and evolving role of PI3 kinase and clinical utility of AKT and the oral SERD. So primarily the resistance either with cell cycle regulator or activation of oncogenic growth signaling mediator. So we have a CDK inhibitors which is cheap. The way we treat advanced breast cancer, and we have those trials, and we all know about them. The Paloma 1, 2, and Mona Lisa 1, 2, Mona Lisa 2, 3, and 7, and Monarchy. The progression-free survival is significantly improved with incorporation of these agents with endocrine therapy. And the only thing that showed the survival advantage is the Mona Lisa trial. However, in the Paloma trial, there's a recent update which showed there's no advantage in overall survival. You can see it here, and this is follow-up for a long time, and there's no advantage also. However, palbociclib has been the widely used agent for a long time, and we use it till now. It's very well tolerated and available and cheaper than the other options. We have the Mona Lisa, which is the first line ribociclib. It's post-menopausal in women with estrogen-positive breast cancer. There's no prior therapy, and prior neoadjuvants is allowed. There were 668 patients randomized to 1-to-1 ribociclib every day for 3 weeks and a week off with letrozole and placebo. And the primary endpoint was progression-free survival and secondary endpoint overall survival. And this is the result of overall survival, which is significant. We showed improvements with ribociclib with the hazard ratio of 0.76 and p-value of 0.004, which is statistically significant. And then we have the Monarch 3 study, which is tested abemaciclib, the same design of the study, with abemaciclib daily dose with in combination with letrozole, and again it's placebo and anastrozole or letrozole. And this is the result of overall survival in intention to treat population. There's a trend to overall survival. However, it's not statistically significant because there's not power for that. And then we have a delta improvement, a numerical delta improvement of 13 months. You can use the CDK inhibitor as a first line, or you can use it later at the time of progression, as is proven by the Sonia study. And That showed no difference if you use it at time progression or use it as first line. And again, if you can use it now with the standard of care we have is for estrogen positive metastatic breast cancer to use aromatase inhibitor in combination with CDK inhibitors, regardless the visual metastasis or heavy burden of disease. This is proven by the White Choice study, which is tested ribociclib in combination with endocrine therapy, and this is a result. It showed a significant difference there compared with combination of chemotherapy in terms of progression-free survival, and is the trend to improve in the overall survival. Again, you can use a CDK inhibitor after CDK inhibitors, as been evidence on the post-Monarchy study, which showed that patient who started on CDK inhibitors, especially with ribociclib or palbociclib. You can use abemaciclib on time of progression in combination with fulvestrant, and it showed at 6 month progression-free survival rate of 50%, and there's improvement there with good hazard ratio of 0.73, so it's a good strategy to use that as well, just to delay using other agents. At this study, they looked at the mutation and resistance, and the subgroup analysis, they found there's ESR1 and BI3 and AKT and PTENT mutation or alteration. And again, using abemaciclib in combination of fulvestrant is on those subgroups is showed response and effectiveness. So, patient, when you decide about optimizing the CDK inhibitor selection, so you have to look at different factors: patient disease-related factors, functional status, comorbidities, GI-related issues, baseline cytopenia, prior DVT. It makes you we have approved 3 agents, so you can select according to your patient factors: pattern of disease, organ functions, bone individual or component brain metastases. We know that abemaciclib have high penetration to the CNS. Palbociclib for only bone disease is mild and well tolerated. Drug-related factors, dosing preference. The patient want to take a daily dose or take it 3 weeks on and a week off. And if there's any concurrent medication can interact with it, like tamoxifen with ribociclib in prolongation of QT interval. And then there's emerging questions you ask yourself: how do molecular genomic factors impact your selection? Is alteration in the first line, PI3 kinase, and according to now we're going to talk a bit later on. And based on observation, we have received adjuvant CDK inhibitor ribociclib, which is going to change the way we're looking to think in the future by the emergence of the CDK inhibitors as adjuvant in the adjuvant setting. Now we move to the evolving role of the BRCA kinase inhibitor for hormone-positive metastatic breast cancer harboring the BRCA kinase mutation. The BRCA kinase and AKT signaling pathway plays a key role in the cell growth, protein translation, autophagy, metabolism, and cell survival. Activating mutation of the B11 alpha catalyzed subunit of BRCA kinase phosphate and tension homolog PTEN loss. An AKT mutation have been identified up to 40% in breast cancer patients, and we call it like a truncal. It's present from the start. Prognostic effect of the BRCA mutations are controversial, as we know, and related to endocrine sensitivity. This is a schematic, very busy, as we focus on here. Oh, sorry. So the BRCA kinase AKTM2 is the most frequent activated signaling pathway in the breast cancer, leading to a tumor growth, as we know, and progression resistant to anti-cancer therapies. And you can find abnormal signaling that has been documented through the different mechanism, mutation or amplification of the B10 loss, growth factor receptors alteration, and crosstalk with others. So what do we need to know about BI3 and B10 alteration? Most BI3 pathways, breast cancer mutation, are clonal, stable from the primary breast cancer metastases. As we said, it's almost around 40%. Minority of the mutation are acquired during the tumor evolution of the therapies, acquired primary breast cancer to recurrence, acquired during the first therapy, the endocrine therapy, like during the CDK inhibitor combination. Activation of this pathway is a mechanism of resistance to the CDK inhibitors, and ESR are more dynamic alterations comparing with the BI3 kinase mutation. They are more dynamic and they tend to accumulate over disease course. The exact proportion of acquired mutations is unknown. It is estimated that 5 to 10% of cancer acquired mutation are evolution for the treatment. So what do we need to know about this? And the BRCA illustration and negative impact survival, there's few studies looked into this. However, the studies have reported conflicted results, which may lead to underlying demographic, clinical, and treatment differences. But that said, they negatively impacting the outcome of the patient if they have harboring this kind of mutation while they take an endocrine therapy. So in 2012, we have the BRCA-1 study, which is tested the everolimus in postmenopausal women, hormonal positive, receptor positive, advanced breast cancer who have developed resistance to endocrine therapy. So they tested exemestane with everolimus. It's phase 3 double-blind randomized trial with refractory to previous letrozole or anastrozole. Primary endpoint was progression-free survival, so exemestane and everolimus against exemestane and placebo. 56% of patients have visceral involvement, 48 previous tamoxifen, 16 fulvestrant. We can see the result there. We can see great separation of the curve with improvement in progression-free survival to 10.6 months in the treatment arm in compared with the placebo arm, which is 4.1 months. Then we have the SOLAR-1, which is a study of, tested alpelisib, which is the only agent that approved for PI3 kinase inhibitor in advanced breast cancer. So it is alpelisib and fulvestrant versus fulvestrant and placebo. We can see here there's a good separation of the curve with median progression-free survival for alpelisib for 11 months versus 5.7 months. However, alpelisib is quite toxic. The people who used it, they found like it's the bare minimum discontinuation of alpelisib due to adverse events occurring 25%. The majority is hyperglycemia. So now, because of the PI3 kinase prevalence as a truncal, we looked at the combination in the first line, the new study, which is we tested inavolisib or placebo in combination with palbociclib and fulvestrant in patient with PI3 kinase mutated hormonal positive, HER2 negative, locally advanced or metastatic breast cancer, which is a NAV 120 primary analysis here. So it's the key eligibility for that is enrichment of patients with poor prognosis, PI3 kinase mutated, hormonal positive breast cancer by central circulating DNA or local tissue or ctDNA test, measurable disease, progression within the 12 months of adjuvant therapy. This is for the people with primary resistance, no prior therapy for advanced breast cancer, and so fasting glucose is supposed to be less than 126 milligram per deciliter, or hemoglobin A1C less than 6%. Patient is stratified where their visceral disease, endocrine resistance or region, and it's 1-to-1 randomization. There were 325 patients on that study. Inavolisib is 9 milligram once daily in combination with palbociclib, 3 weeks on and week off, in addition to fulvestrant. Continue the treatment until disease progression, and the primary endpoint progression-free survival investigator. Secondary endpoint was overall survival, overall response rate, and others. The demographic and baseline characteristics are equal in both arms. And the primary endpoint by investigator assess, you can see significant separation of the curve there. There's improvement on the progression-free survival. And they put a time point, 6 months, at 12 months, and 18 months, and that persistently improved during time with a hazard ratio of 0.43. However, if you look at the number, it's 50, median overall progression for 15 months versus 7.3 months. It's doubled. It is persistent through all the subgroup analysis. They're all positive. Yeah, no matter you have visceral disease or not, number of metastases. So it's all in favor of the triple therapy. And the secondary endpoint, there's a hint of it's premature, but there's a hint of improvement of overall survival. And secondary endpoint, we said earlier, overall response rate and clinical benefit rate. There's a delta of 33.4% improvement of overall response rate and a delta of 28.2 improvement on the clinical benefit rate for the triple therapy in comparison of the doublet therapy. And this is recently kind of presented in the ASCO last year. And so what is the safety? Is there any safety signal compared with alpelisib? There's no major safety difference. However, the rate of the hyperglycemia, diarrhea, and rash is stomatitis is less, and they are reversible. And sorry. And the time of the onset of this adverse event is usually occur early on the therapy, the first or the second week of the treatment. So if you recognize them and you positively affect, treat them, you can prevent. And the discontinuation rate is very little. It's only one patient discontinued the treatment due to adverse events. So it's become like a first kind of line of standard of care for people who develop resistance to the adjuvant therapy when you if they harbor the PI3 kinase mutation. So now we move to the clinical utility of KT inhibitors for patients with progressive hormone-positive metastatic breast cancer. The frequency of AKT pathway alteration in hormone-positive breast cancer, you can see PI3K kinase mutation is between 28 to 46%. The AKT mutation is up to 11%, and P10 mutation is 14%. So we can do the Capitello 291 study, which is a phase 3 randomized, double-blind, placebo-controlled study for women or postmenopausal women and men with recurrent or progressive while on less than 12 months from the end of the adjuvant endocrine therapy, or progress while they're on endocrine therapy for advanced breast cancer. If you have 2 lines of prior endocrine therapy allowed, less than 1 line of chemotherapy as well allowed, prior CDK inhibitors allowed, at least 51% required. No prior SERT, M2 inhibitor, PI3 inhibitor, or AKT inhibitor, and hemoglobin A1C should be less than 8%. And diabetes not requiring insulin allowed as well in that trial, and you're supposed to have a tissue sample. So it is 1-to-1 randomization. It's capivasertib, 400 milligrams twice daily, 4 days on and 3 days off, in combination with fulvestrant and placebo and fulvestrant. And patient is stratified according to liver metastases, prior CDK inhibitor, and region. The primary endpoint was progression-free survival investigator assessed, an AKT pathway altered tumor, and the progression-free survival for people with PTN alteration. Key secondary endpoint, overall survival in the overall population, and overall survival in AKT pathway altered tumor, and there's an objective response rate as part of the secondary endpoint. The basic characteristic for the patients enrolled in this trial are equal in both arms, and prior treatments the same, equal in both arms, and the AKT pathway alteration is equal in both arms here. And this is the result of the primary endpoint, investigator assessed progression-free survival in the overall population. There's improvement in the cabi fulvestrant arm from 3.6 to 7.2 with a hazard ratio of 0.60. And this is for people as well as notice that in people who's not altered mutation, the same benefit is there. However, the hazard ratio is only 0.70, but it's improved from 3.7 to 7.2. And the first plot showed that in favor of the combination in all subgroup analysis. And again, the overall response rate is improved as well. In the overall population, there's 22.9% improvement compared with the placebo arm. And when you look into the AKT pathway altered population, there's 1.9% they have complete pathological response, and 22.6 with good partial response, and 54.2 is stable disease. Overall survival at 28% maturity is not mature yet, but there's a hint of improvement in overall survival. And the safety, there's no new signal of any new side effects compared with the alpelisib and the inavolisib. However, the rate of toxicity is less, and that likely could be because it's 4 days on and 3 days off. And the main side effects are diarrhea, rash, hyperglycemia, and stomatitis. As we mentioned, diarrhea, rash, stomatitis is 72% under diarrhea, but can be managed as with antidiarrheal treatment, and people continue with treatment without any major problems. The management of frequent adverse events as per the study, just mentioned there. The clinical study protocol specify management of CABI-related adverse events, diarrhea, rash, and hyperglycemia. Is very helpful in practice. So you have, if you follow those, hopefully your patients will be tolerating it well and with good quality of life, and to get the maximum benefit of the treatment. So when we do the testing for the BI3 mutation, so timing of testing remain a subject of debate, and ongoing trial will define the need for biomarker information at different moments in the journey of the hormone-positive breast cancer. A patient with BI3 kinase mutant breast cancer can be identified by molecular analysis of tumor DNA using both tissue and blood-based PCR or NGS technologies. As I mentioned earlier, BI3 mutation are mostly truncal, about 40%, and the acquired one is only kind of around 11%. So the suitable sample, fresh frozen tissue, or tissue sample from primary tumor or metastatic sites, or archive specimen. So the cabirasib plus fulvestrant provide a statistically significant improvement in progression-free survival. Benefit from CABI was consistent across, as we mentioned, across clinical relevant subgroups, and including patients with AKT pathway altered tumor and patients with prior CPK inhibitors who received only 1 line of chemotherapy, they benefited as well, and patients with metastatic liver disease. Diarrhea, rash, and hyperglycemia are most frequent side effects with AKT pathway inhibitor reported with CABI versus fulvestrant. However, they are manageable and compared with other agents like PKSA inhibitors, alpelisib, and others. So there's ongoing phase 3 Capital 292, which is looking at combination therapy, tablet therapy with CABI and CDK inhibitors and fulvestrant, and hopefully we'll get this result in the near future. This is the NCCN guideline for the biomarker and targeted therapy. So for advanced hormone-positive breast cancer, BRCA kinase, you can do the NGS is positive. You use inavolisib or palbociclib and fulvestrant in the first line setting, or alpelisib in the second line setting. If you have AKT alteration, then cabivertib and fulvestrant, and they're all category 1. And we're coming to the ESR in the next minute. So now we'll look into the oral SERT, which is selective estrogen receptor degrader for the hormone-positive metastatic breast cancer.
So, you have another 2 minutes.
Okay, I will go quickly. So the ESR mutation is primarily acquired mutations. It's rarely to find in the primary tumor. And and they are increased by time. And more prevalent after the CDK inhibitor, we can discuss clearly there. And we can, this is a data set from the SOPHIA and EFFECT combined analysis, which is showing the predictive value of the ESR mutation, showing the inferior outcome for patients who harboring those mutations. And this is patients who receive exemestane or fulvestrant after progression of aromatase inhibitors. The pink line is the exemestane and the red line is fulvestrant, and that's clearly showing that people harboring or developing ESR mutation, they have a worse outcome. Then we come to the MLAT phase 3 study, which is tested patients with advanced breast cancer, progressed or relapsed on or after 2 lines of endocrine therapy, and they received the CDK inhibitors, and 1 line of chemotherapy for advanced disease is allowed, and they have to be like in good performance status. ESR1 mutation status is stratified the patient as well as prior treatment. So it is a lestrant 400 milligram daily, which is a new oral SERD and the only one approved so far. Investigator choice fulvestrant, anastrozole, letrozole, and exemestane. And the primary endpoint, progression-free survival in all patients, and the progression-free survival in ESR mutant patient. This is the result. We can see there's a significant improvement statistically, which is improved from 1.9 months to 3.8 months for the whole population. And then we go to people with ESR mutants, and you can see that improvement at 6 months is improved to from 40.8 compared with 19.1, and progression at 12 months is improved to 26 compared with 8.2. And when they looked at the exposure to the CDK inhibitors, the longer the exposure, the longer the benefit. So at least 6 months CDK inhibitors, as we say, the prevalence of the mutation increased by time. So you can see that's a good separation and maintain separation and get better by time. So when we come to 18 months, there's improvement from 2 months to 8.6 months, which had a ratio of 0.466. And then when we looked into the prevalence of other mutation, so there's the only no benefit if they have BIC kinase mutants. Otherwise, there's still little benefit across all other mutations. Then we have the EMBER study, which is recently published and presented in the San Antonio, which is another oral SERD. It's called imlunestrant, which is for people who had adjuvant therapy recurrent on or within 12 months of completion, where advanced breast cancer progressed on the first line with aromatase inhibitor and CDK inhibitor, stratified by prior CDK, visceral metastases, and region. It is 3-arm, arm A, B, and C, which is imlunestrant single agent, and then standard of care, either fulvestrant or exemestane, or imlunestrant in combination of CDK inhibitor abemaciclib. So the primary endpoint, A versus B, in patients with ESR1 mutation, or A versus B in all patients, or C versus A in all patients. And the secondary endpoint of overall survival, progression-free survival, and there's an exploratory endpoint with progression-free survival and overall survival for C versus B, and in all patients. So we're interested in imlunestrant versus as standard of care. This is a slight difference, but statistically it's significant. It has a ratio of 0.62. However, when we come to the combination with imlunestrant abemaciclib versus the standard of care, we can versus imlunestrant single agent, we can see significant difference there. And this is published after the San Antonio in the New England journals. There's other oral SERD that have been in the go, the camizestrant, and then we have the AMIR study, which is testing misestrant. So they're all in the go, and when we have the results, we can present them in a different future meetings. Because of the time, I'm just going to skip all of them. So we the one that we are on test now, we have illustrant, which we know, imlustrant, camizestrant, and giredestrant. The adverse events are very manageable: nausea, fatigue, vomiting. The only thing is specific for the camizestrant is visual disturbance and bradycardia, and they need special attention. There's another Serena study, which is an ongoing, very smart design, but we have no time to go through that. Serena 4, testing combination with camizestrant and palbociclib as first-line therapy. And we have the treat ctDNA and lidERA, breast cancer trials. There's a lot of trial going on the oral SERD. So there is more updates recommendation for the NGS breast. So you do we go down to the HER2 positive, the hormonal positive cancer. So you PI3 kinase, 30-40% prevalence. And we have ESR mutation, BRCA, PTEN, AKT1, and BALB1. So this is just treatment journey for metastatic breast cancer. You have the diagnosis, the time, initial adjuvant therapy with distant recurrence or first-line therapy. Progression-free survival is longer. So with the endocrine therapy, with CDK inhibitors, progression, you move to the second line and you do your NGS and to see if there's any sign of resistance, or you can pick up PI3 kinase a mutation, and then you can, or if you have BRCA, you can use BARB inhibitors or KT inhibitors if you have AKT alteration. So remember, diagnosis. So this is the biological marker you need when you have an initial diagnosis: UAR, PR, HER2, BRCA, BALB. If you have the advanced de novo metastatic breast cancer, that's what you need to know about the molecular analysis for your tumor. ER, PR, HER2, BRCA, BALB. They have harboring PI3 kinase or AKT or patent just for future option of treatment. You start your endocrine therapy with CDK inhibitors. Progression after time. You repeat your test to see if they develop any acquired mutation. And then you move to the second line endocrine therapy. Third endocrine therapy, the time of progression, you do another genomic testing. Maybe you get another agnostic marker, HER2 low, and you move to the first line chemotherapy, second line chemotherapy, ADC, and then we go to the end of life care. And remember, you do circulating DNA at time of progression every time if you can. Thank you for rushing you through it. Too much slide. Thank you for listening.
So it's my great pleasure because of my friend, I can see the screen, senior oncologist, Dr. Simon, oncologist, and so when we was talk, often right now.
Thank you very much, Dr. Muhammad. It's my pleasure to join this meeting with you and with our dear colleague, Dr. Samah Al-Rahili. I would like as well to thank our friends from National Guard for the appreciated invitation to present this talk about management of BRCA-associated breast cancer. Dr. Muhammad, I hope that you can see my slides well. Okay. So this is the agenda of this talk. I will try to finish on time, inshallah. This is we'll talk about in brief about BRCA testing, risk reduction approaches in patients with BRCA mutation, and how to manage patients with BRCA mutation in the metastatic breast cancer and early breast cancer. So first of all, you know the role of BRCA1 and BRCA2 proteins in addition to BALB2, RAD51, which are the major component in the homologous recombination pathway. They are involved in the repair, especially in double-stranded breaks. And if you have abnormality in one of these key proteins, there is a chance to have a lot of accumulating mutation, especially the alternative repair pathways like classical non-homologous enjoining are not that perfect in repairing the double-stranded DNA breaks. So there is accumulation of mutation, and it will end up by development of cancers. If we look to the risk of having breast and ovarian cancer in patients with BRCA mutation, for breast cancer, the risk of development of breast cancer, the lifetime risk reach up to 70% in patients with BRCA1 and BRCA2 mutation, as you can see in this diagram. And the risk started in the age of 30s. While for ovarian cancer, the risk is higher for BRCA1 compared to BRCA2, 40% lifetime risk compared to about 20%. And we have 10 years later, at the age of the start of the risk of development of ovarian cancer with BRCA2 mutation. Okay, but in addition to BRCA1 and BRCA2, we have the increasing interest in testing for PALB2 because you know there is a significant risk of having breast cancer reaching up to 50% lifetime risk for breast cancer for patients having germline PALB2 mutation. And if we look to the recommendation for testing across different guidelines, we'll focus on the NCCN. This is a version 2024, which is the same for the 2025 version. You know, the advice for testing for BRCA mutation, the patient having a development of breast cancer younger than 50, or at any age for patients having positive family history, male breast cancer, or having triple negative breast cancer or multiple primaries, in addition to if there is an indication or potential indication for systemic treatment with PARP inhibitor in the adjuvant or metastatic setting. But, you know, we have many series of patients that found that if we stick to these guidelines, especially starting testing for patients diagnosed less than 50, we can miss up to 10 to 15% of patients who turn out to have the BRCA mutation. So the ASCO recommendation are more liberal. The advice for testing for any patient diagnosed with breast cancer younger than 65. And I think which one to adopt, it depends on many factors, including the logistics, the availability of the test, and the cost and economic scenario as well. So if we move to the different risk reduction approaches, I will present this abstract, which have been presented in the last San Antonio 2024. This is a large series of patients coming from different parts of the world, including more than 5,000 patients with BRCA mutation. And they looked for association between different risk reduction surgeries on the survival in patients with BRCA mutation. And this is the approach of the comparison here. They included more than 5,000 patients. They compared patients who have risk reduction mastectomy compared to nothing, and no prophylactic risk surgery. And they compared as well those who have risk reduction salpingo-oophorectomy versus not. And they found that for the risk reduction mastectomy, prophylactic contralateral mastectomy, they found that having this kind of prophylactic surgery confers overall survival benefit with a hazard ratio of 0.65. So it's not only decreasing the risk of contralateral development of contralateral breast cancer, but it has an impact as well on overall survival according to this analysis. And the impact as well is similar in terms of disease-free survival and breast cancer-free survival. And if we move to the impact of risk reduction salpingo-oophorectomy on the survival outcome, we have as well improvement in overall survival, 0.58 as adjusted hazard ratio. And the impact here is more pronounced in patients having BRCA1 mutation compared to patients having BRCA2 mutation in terms of impact on overall survival. It decreases, of course, the risk of development of ovarian cancer, but the impact on survival is more pronounced in patients with BRCA1 mutation. And this can have an impact during the discussion of the patient for the risk reduction strategies. And risk reduction salpingo-oophorectomy has its impact as well in terms of prophylaxis against breast cancer. So you can see here that there is improvement in disease-free survival and breast cancer-free interval for patients who have risk reduction salpingo-oophorectomy. So I think with this data, despite that we have a different series of patients published several years ago, we have different publication for that, but this is the most recent one, and this is one of the largest series, and this data may have an impact during the discussion with the patient for risk reduction strategies. Moving to the therapeutic implication in terms of systemic therapy. So we'll start first with the systemic treatment for patients with BRCA mutation in metastatic breast cancer. You know, these are the two famous trials, Olympiad and IMBRCA, where eligible patients were randomized between olaparib versus chemotherapy or talazoparib versus chemotherapy. And what we need to know here is they allowed recruitment of patients who received up to 2 lines of treatment in the Olympiad study, and in the BRCA up to 3 lines of previous chemotherapy. This is for triple negative. For hormonal receptor positive part, it was mandated that the patient should receive at least 1 line of previous hormonal therapy. And they allowed recruitment of patients who received the previous platinum therapy if there is a reasonable disease-free interval before having relapse. More than 12 months in the Olympiad and more than 6 months in the BRCA study. The hazard ratio in terms of PFS more or less comparable, 0.54 and 0.58 in favor of talazoparib and olaparib. And if we look to the response rate, it's more than doubled in favor of talazoparib and olaparib. As you can see here, we can reach up to 60 or 63% response rate for the PARP inhibitors. But the question now that we need to discuss, if you have a patient with BRCA mutation, we know that those patients are responsible to platinum as well. Shall we go ahead with platinum-based therapy or PARP inhibitor? I think different factors need to be taken into consideration, but the first, before considering which one of them, do we have any head-to-head comparison in that setting? Actually, in the metastatic setting, we don't have head-to-head comparison between platinum-based therapy versus PARP inhibitor. But we have a randomized phase 2 study in the neoadjuvant setting for patients with BRCA mutation in GEBAR-OLA study, where patients were randomized between neoadjuvant anthracycline-based therapy in addition to paclitaxel plus olaparib or paclitaxel plus carboplatin. And if you look to the right side of this diagram, you can see that there is no big difference in terms of PCR between the two arms. This is a small study, but we don't have that impression that we have that big difference between using PARP inhibitor versus platinum, but this is in the neoadjuvant setting. In the metastatic setting, we don't have data up till now. But other factors need to be considered before choosing either of them in the metastatic setting. The first is the PD-L1 status. If the patient is PD-L1 positive, I guess starting with chemo plus immune therapy may be a reasonable choice because we don't have data for immune-based therapy, or we don't have significant data for immune-based therapy beyond first line. So we can go with immune-based therapy in addition to chemo, either platinum or others, and then we can go for PARP inhibitor in later lines. But other factors that we need to consider as well, like toxicity profile, cost and availability, you need to discuss with the patient the expected side effect from both agents, the route of administration, and we can make the decision at that time. But one of the factors that we need to consider is, what about the PARP inhibitor in patients who received the previous platinum-based therapy, because we know that there is some overlap in the mechanism of resistance between the two agents. So in the BRCA study, if you look to the patient, the outcome according to prior use of platinum, the benefit is consistent, and this was the same in the Olympiad as well. As you can see in this diagram. So what's important here is the duration before the last dose of platinum before using PARP inhibitor. In the phase 2 APRAZO study with talazoparib, they looked for the outcome according to the interval before the last dose of platinum therapy. And the overall conclusion here is the longer the better. And in my opinion, as you can see in this diagram, that 6 months or more before the last dose of platinum is a reasonable cutoff to get good outcome with PARP inhibitor after platinum. As you can see that PFS here is about 7 to 8 months. So at least 6 months is fine between platinum and PARP inhibitor to get good outcome with PARP inhibitor therapy in the metastatic setting. The point is, the next point that I need to discuss with you, if the patient presented with visceral crisis, traditionally we are going with chemotherapy, but the question is, can we use PARP inhibitor in that setting? If you look to the NCN recommendation for patients with hormonal receptor positive HER2 negative, you can see that the recommended for the use of PARP inhibitor in patients with endocrine refractory or visceral crisis. But what is the basis of recommending PARP inhibitor? Of course, chemotherapy is a good choice as well, but what is the basis of PARP inhibitor here? If we look to the data that we have, we can have high response rate, 60%. And the median time to response is not that long. It is 45 days, more or less similar to chemotherapy. And if we compare this data, even with the data coming from first-line setting in the TNAT study, comparing platinum versus docetaxel, this is an old study, you can see that for BRCA mutant patient, the BFS, median BFS in first line with platinum was 7.5 months, and the response rate was in the range of 60s as well. So again, PARP inhibitor having more or less similar outcome in terms of response and duration of response and BFS compared to platinum, but this is indirect comparison we need to take with caution, of course. The next point that we need to discuss, what to do, how to make use of PARP inhibitor in early breast cancer. We'll start with briefly in hormonal positive, then we'll go for triple negative. For the hormonal positive part, we know that for patients with high-risk hormonal receptor positive HER2 negative, the risk of relapse is higher in the first 2 to 3 years. Of course, the risk of relapse can persist, but we have high risk of relapse in the first 2 to 3 years. So we need to maximize our tools in these these first years of the adjuvant therapy to decrease the risk of relapse as much as we can. And the tools that we are using to decrease the risk of relapse include adjuvant chemotherapy, optimizing adjuvant hormonal therapy with ovarian function suppression plus aromatase inhibitor, or extending adjuvant hormonal therapy beyond 5 years. We have good data for that. Using bone-modifying agent, especially zoledronic acid, it can decrease the risk of relapse as well. And more recently, in the last few years, we have additional to use additional 2 tools, which are CDK4/6 inhibitor and olaparib. So for the olaparib, this data comes from the Olympia study, where which included patients with hormonal receptor positive and triple negative. For the hormonal receptor positive, we need to have 4 more lymph nodes in the adjuvant setting, or we need to have residual disease, significant residual disease after neoadjuvant therapy with CBS EG score 3 and more. For triple negative cohort, we need to have any residual disease or the pathological T2 or any node positive T2 pre-recruited in the study. And this is the updated overall survival published in last San Antonio. After a median of 6 years of follow-up, we can have an absolute delta of improvement in invasive disease-free survival of 9.4 months compared to 9.4% compared to 8.4% with the previous analysis of 4 years of follow-up. This is in terms of invasive disease-free survival. So even with longer follow-up, we have better improvement in invasive disease-free survival. And the benefit was consistent in the triple negative and hormonal receptor positive cohorts, as you can see in this diagram, and the same hazard ratio. And if we look for the overall survival, with 6 years of follow-up, we have 4.4% compared to 3.2% at the previous analysis. So again, the longer the follow-up, the better invasive disease-free survival and the better overall survival benefit with only 1 year of adjuvant olaparib. And even there is some decrease in the risk of new primary malignancy, including breast, ovarian, and pancreas. And this are some of the BRCA-associated breast malignancies which decrease with the use of adjuvant olaparib, which raises the impression whether the use of adjuvant olaparib is one of the risk reduction strategies even for the new malignancies associated with BRCA mutation. And we can discuss that at the discussion part. If we compare the other tool, which is CDK4/6 inhibitor, we have improvement in invasive disease-free survival, as you can see in this diagram, 7.6% at 5 years of follow-up. However, we don't have overall survival benefit up to now. And we have data published 2 to 3 years ago that having BRCA mutation may confer some resistance to CDK4/6 inhibitor in the metastatic setting. But we don't have this data in the adjuvant setting, but in the metastatic setting, we have data for that. So if we put everything in comparison, so which one to use if you have a patient with BRCA mutation and eligible as well for CDK4/6 inhibitor? I think my preference, and we can discuss that, adjuvant olaparib should be part of the adjuvant therapy, either alone or in sequence with olaparib followed by CDK4/6 inhibitor. Despite that, we don't have data for the sequence, but olaparib should be there as part of the adjuvant strategy. And the reason for that is it is 1 year versus 2 or 3 years with CDK4/6 inhibitor. We have overall survival benefits with olaparib we don't have with the others. And it's a kind of precision medicine, of course. And the concern of resistance to CDK4/6 inhibitor in BRCA mutation should be considered. For this reason, adjuvant olaparib is preferred in setting over CDK4/6 inhibitor. But what to do for patients who have high risk but they don't meet the inclusion criteria of the Olympia study, like patient with N1 disease with hormonal receptor positive status. And we have this frequent scenario. We have a patient that with N1 disease, and we test for oncotype test for post-menopausal patient to guide for chemotherapy. And if the oncotype score recurrence score came to be high like this patient, shall we go with adjuvant olaparib despite it's not included, does not meet the inclusion criteria of the study, or shall we stick to the study population? I think this is a kind of debate and discussion, and it should be considered case by case. Okay, lastly, we'll move to the use of PARP inhibitor in the early triple-negative breast cancer. The tools as well to decrease the risk of relapse in triple-negative breast cancer, including chemotherapy, especially dose-dense chemotherapy. And we have data recently to add platinum to, of course, we have data to the benefit of platinum as a part of the neoadjuvant chemotherapy. And of course, immune therapy as well can decrease the risk of relapse. But the matter of debate is if the patient having residual disease after neoadjuvant therapy, including pembrolizumab, which one to use, pembro, maybe capecitabine, or olaparib. So this is a keynote, the famous keynote 522, including patient who received neoadjuvant chemotherapy plus or minus pembrolizumab. And we know the survival benefit of the adding pembro to chemotherapy. This is well known. But and we know that patient having residual disease who received the pembrolizumab having better event-free survival compared to the control arm. But if you have a patient with residual disease, received the neoadjuvant chemotherapy plus pembrolizumab, and the patient came to have BRCA mutation, what would be your post-neoadjuvant strategy? To make some suggestion for that, if we look to this exploratory analysis published 2 or 3 years back, you can see that for patient with residual cancer burden 3, that's to say very large residual cancer burden or minimal response to neoadjuvant therapy, including pembro, we don't have that great benefit for the pembro arm compared to the control arm. But the benefit actually is more pronounced with residual cancer burden 2, where we have some residual disease, but we have some evidence of response, good response as well to pembro with chemotherapy. So these are the population who may benefit from pembro, but patient with significant residual disease with minimal response, it seems that we don't have that benefit from pembro. And in those population, we need to look for other strategies to decrease the risk of relapse, including olaparib. So my suggestion is if the patient have very poor response to neoadjuvant chemo with pembro, like residual cancer burden 3, here olaparib should be our choice, not continuing pembrolizumab. But for patient with good response but still having some residual disease, we have many options to use. You can go with olaparib alone, or you can complete the full course of adjuvant pembro followed by olaparib. Or even you can, one practical approach is to use pembro during adjuvant radiotherapy, where we cannot use olaparib. And then after finishing radiotherapy, you can go with olaparib. So this is my final slide. For BRCA testing, we got more liberal testing strategies with time, of course, with the wider availability of the testing platforms and reducing the cost. And for risk reduction approaches, there is nowadays we have accumulating evidence of the survival benefit for risk reduction salpingo-oophorectomy, and recently in the last San Antonio we have a larger series of patients demonstrating survival benefit as well for risk reduction mastectomy. And in the metastatic setting, which we want to use PARP inhibitor or platinum, many factors should be considered, as we mentioned before, and there is no right or wrong here. For adjuvant therapy in patients with early hormone receptor positive HER2 or negative, I would prefer to use olaparib for the majority of patients. But what to do in patients with N1 disease, this is a matter of debate. For BRCA mutation in as an early post-adjuvant therapy in triple-negative breast cancer, PARP inhibitor with olaparib versus pembro again should be discussed. But I think for patients with no response at all or minimal response to pembro, olaparib should be our priority. Thank you very much.
Thank you very much, Dr. Sharif, for this elegant presentation. Now we'll switch gears to thoracic oncology, and our next speaker is Dr. Ahmed Al-Lahabi. Dr. Ahmed Al-Lahabi is a very well-known medical oncologist with the specialty in the lung and GI from King Faisal Specialist Hospital in Jeddah, and he will enlighten us about updates in the targeted therapy in non-small cell lung cancer. Dr. Ahmed.
Thank you so much, Dr. Samah, for the kind introduction. I'm really humbled by those kind words. I just want to confirm, can you guys see my screen?
Yes.
Okay, thank you. So I'd like to extend my thanks and gratitude to the chairman of the conference, Dr. Kanaan Shamri, and Dr. Mohammed Al-Garni, for the kind invitation of myself. I'm really humbled to be a speaker in this prestigious event. I would have loved to be there in person. You guys always know that I'd love to be there in person, but unfortunately I'm on call. So next time, inshallah, I'll be there physically. Inshallah, I'd be delighted to see you. So I was given the task of talking about actionable mutations. So basically the updated landscapes and targeted therapies in metastatic non-small cell lung cancer. I entitled this particular presentation. As you can imagine, there is a huge evidence that we need to cover over the next 20 minutes or so. So these are the main subtypes of drivers mutations that we're going to be going over. I'll try my best to squeeze in the time to go over the majority of the most important evidence and the most updated ones as well that we think that is going to be practice changing. So starting off with the EGFR mutations. So as we all know, we all are aware about the FLORA study with the use of osimertinib in the metastatic setting. So now we're going to incorporate the FLORA-2, which is basically giving osimertinib along with chemotherapy in metastatic non-small cell lung cancer with significant evidence that it actually had shown improved PFS, and most recently there's improved OS, which I failed to put in the slides here because I wasn't able to pull that up, fortunately. But it is quite significant to understand that use of osimertinib on its own is beneficial. However, the addition of chemo to osimertinib had shown PFS up to 30 months. And most importantly, people or patients with CNS metastases gained the most benefit, with the PFS reaching up to 25 months versus 14 months in favor of the chemo plus osimertinib. And it seems that there is significant prophylactic measure of delaying the presence of CNS metastases by up to 28 months versus osimertinib. The downside of the intervention of chemotherapy plus osimertinib is the side effect profile, the usual side effect profile that you can have from the addition of chemotherapy, plus an increased risk of ILD, as you can imagine, when we give chemotherapy to osimertinib. So something to be kept in mind for these patients. Now switching gear to MARIPOSA-1 with the use of amivantamab plus lazertinib in the first line treatment option in patients with EGFR positive mutation versus osimertinib and versus lazertinib. As you can imagine, and we all know that the study is positive. PFS is significant for the use of amivantamab plus lazertinib as opposed to osimertinib, with the PFS reaching up to 24 months with a hazard ratio of 0.70. What's striking about this particular medication or regimen is that it is chemo-free and has showed significant activity against the notorious exon 21 mutation, which basically was not as much improved with the use of osimertinib and when being compared to amivantamab lazertinib. So that's one option for which we can overcome the obstacle of the exon 21 mutation, as well as the improvement in brain metastases. As you can see here on the left-hand side of the slide, people or patients who would have brain metastatic disease in the setting of EGFR mutation, regardless of the subtype, these are the common mutations, not the uncommon ones. There's significant improvement to the hazard ratio 0.69, and patients without brain metastases, there was prophylactic improvement or measures of delaying in presence of brain metastases with this chemo-free regimen, as you can see there. Safety profile, it is quite safe. However, infusion-related reaction is a truthful thing and something that we have to keep a close eye on. But with proper pre-medications, I never had any issues with infusion-related reactions with amivantamab. However, there is a risk of interstitial lung disease and some increased toxicity related mostly to the EGFR component of amivantamab as opposed to the MIT14 component. So the MARIPOSA-2 is basically the second-line treatment option for which we can offer our patients who had progress on the first-line osimertinib, and that is in the form of amivantamab chemotherapy. It's a 3-armed study. The first arm is amivantamab lazertinib and chemotherapy versus chemo versus amivantamab chemotherapy. And the dual primary endpoint is basically looking at the use of the triplet versus amivantamab chemotherapy in this setting. And what was striking about this particular study is that it was positive for both arms, the triplet versus the doublet amivantamab chemotherapy. And it was shown that with amivantamab chemotherapy, the side effect profile was better, and hence it would be the most appropriate option as opposed to the triplet regimen with the hazard ratio of 0.44 in both arms with a significant p-value, as you can see there. Something to be kept in mind with the use of amivantamab chemotherapy, there is always an increased risk of DVT by 4%. Hence, people or patients would require prophylactic enoxaparin upon the initiation of amivantamab plus chemotherapy. So we need to keep that in mind. So the PALOMA-3 is the first positive study that was done in the exon 20 insertion with the use of amivantamab plus chemotherapy versus chemotherapy alone. As we all know, the exon 20 has been notoriously not responding to any TKI until the amivantamab chemotherapy in the Papillon study was conducted. And now finally we have a positive result with a significant PFS reaching up to almost 11 months versus 6 months with a hazard ratio of 0.3 and significant p-value. And that had been standard of care since then. I know that the exon 20 insertion is not the most common mutation that we'd face in EGFR mutation. So we have to keep in mind that once we run into those kind of mutations, we need to start amivantamab chemotherapy. Hence, that speaks about the importance of having such a medication in our artillery, in our hospitals. So moving on to the PALOMA-3, and the significance about the PALOMA-3 that it had looked at the use of subcut amivantamab plus lazertinib versus IV amivantamab with the idea that it decreases the risk of the infusion-related reactions and other side effects that we can have from IV amivantamab. Definitely overall survival was equivocal with some slight improvement with the subcut amivantamab because of the consistency of the medication as opposed to delays and dose reductions. And as you can imagine, the infusion-related reactions was decreased from 66% to 13%, and the rest of the reactions as well, as you can see there. Hence, we are looking forward to have that subcut amivantamab approved by FDA by this October 2025, and hopefully we're going to have it in our hospitals by 2027. So switching gears to the ALK1 positives, we're all aware about the CROWN study. It has been practice changing since it was published. The CROWN study looked at the use of lorlatinib versus crizotinib in patients with metastatic ALK1 positive. And it is one of the best medications that had been used in that field. The overall survival is not published yet. PFS is counting more than 60 months with a hazard ratio of 0.19. And most importantly is that its effect in brain metastases. It goes in parallel with the x-axis in terms of prophylactic measures, almost to patients with the ALK1 positives. Even in patients with brain metastases, there is significant improvement with the reduction in size of those brain mets with a hazard ratio of 0.08. So it's one of the best medications to be used in that field. Even when we look at the poor prognostic variants like the variant 1 and 3 and the p53 mutations, the lorlatinib triumphed crizotinib in that field, as you can see there, as per the blue line in the Kaplan-Meier curves. So switching gears to the RAS mutation with the use of sotorasib as per the code break 200 and 300s, but mainly here is the 200. It is a phase 3 study that looked at the use of sotorasib versus docetaxel in the third-line setting and beyond in G12C mutated patients. And the main idea is to look at the PFS, which was positive, with a significant response rate in favor of sotorasib. But most importantly, we all know that the overall survival was not significant. However, the side effect profile was more tolerable with sotorasib as opposed to docetaxel. Hence, that had gained its access for these patients with the G12C in the third line and beyond treatment. How about the crystal study with the use of adagrasib? Again, the same concept as the sotorasib, third line and beyond, and that the use of adagrasib versus docetaxel, significant improvement in PFS with a hazard ratio of 0.58. Again, the side effect profile was more tolerable, maybe some slight increase in diarrhea, vomiting, and nausea, but was mostly in the grade of 1 to 2, and that was very easily manageable as opposed to docetaxel. Hence, both of these medications can be given in that setting of G12C in the third line and beyond. RET mutation with the use of libretto, the study, and the medication is silpercatinib. The overall response rate was in favor for the use of silpercatinib in patients who are treatment naive, and even in patients who had been previously treated, they had significant improvement of overall response rate and duration of response and PFS. However, it seems that patients who had been treatment naive gained the most benefit as opposed to the ones who had been treated previously. It is a category 1, basically to use silpercatinib in the first line setting in patients with RET1 and the RET mutation. As you can see, most of these patients had partial responses as opposed to complete responses. And moving on to the MYT14 skep mutation, there are two more important medications. The first one is capmatinib, and if I'm gonna pay your attention or draw your attention to the upper half of the slide with the use of with the response rates in favor for the use of capmatinib in this particular mutation in patients who had not been treated gained more benefit than patients who had been previously treated with other TKIs or chemotherapy, and the PFS again showed to be the best in patients who had never been treated, so treatment naive, as opposed to the ones who had been previously treated, as per the lower half of the slide there. Tepotinib, again, it's another option for this particular mutation. The main differences between those medications are the side effect profile. So one of the medications, mainly the tepotinib, can increase the risk of pleural effusion, and the capmatinib, there's an increased risk of shortness of breath and query ILD as well. So it all depends on the unique patient's characteristics for which you would apply your choice accordingly. Switching gears on to the HER2 amplification with the use of trastuzumab deruxtecan. As we all know, trastuzumab deruxtecan had gained its fame in across a lot of cancer sites, but here, even in lung cancer, there is an option where we can give trastuzumab deruxtecan in subsequent lines of treatment, and there's two main cohorts. The first cohort is the IC positive, IC 2 and 3 positives, versus HER2 mutated. I'm going to remind you that these are patients who had been heavily pretreated in the past. Response rates were in favor of the use of trastuzumab deruxtecan as well as a PFS. ROS1 mutation, we all know the use of crizotinib, but are there any other options? Yes, we have newer options with the use of entrectinib, sorry. I'm going to mention that in ROS1 mutations, most of these studies are phase 1-2 studies because of the small number of mutations of patients that would have this particular mutation. So entrectinib had shown significant overall response rate up to 70% in patients who in overall population, but in patients with brain mets, basically there's a response rate of 70%, and even in patients without brain metastatic disease, there is prophylactic measures improvement for development of any brain metastases with the use of entrectinib. PFS was in favor for the use of entrectinib as well as overall survival. So that's one option that we can consider in these patients. Are there any second line options? Yes. Lorlatinib with significant improvement in CR and partial responses and even PFS and overall survival in this particular setting. And it was shown that patients who had never been treated with any TKIs gained more benefit with the use of lorlatinib as opposed to the ones who had been previously exposed to crizotinib and had progressed on crizotinib. So that's another option. There's another option, not particularly in the second line setting, but in the first line setting with a Trident study, the repotrectinib in patients who had been treatment naive you can see that it goes in parallel to the x-axis, although the number of patients are quite small, but it is an option that we can think of and has been introduced only over the past couple of years. How about the BRAF mutation? We have the FARO study. It is a phase 2 study that looked at the use of encorafenib, binimetinib in patients with metastatic non-small cell lung cancer, previously been treated, treatment naive. The treatment included either single immunotherapy or dual immunotherapy. Again, the overall response rate in patients who had never been treated was about 75%, mostly partial responses. Even the ones who had been previously treated with immunotherapies still gained significant benefit. However, this particular regimen does not come in without a significant side effects, and I've got to say most of them are serious side effects, up till 38%, with fatal adverse events up to 22%, and mainly hemorrhages, increased QTc, and other cardiac issues that still can happen with this particular regimen. So a lot of education needs to come in or around this particular regimen. So lastly is the NRG1 mutation. As we all know, the zenocutuzumab with the NRG1 fusion had been looked into various cancer sites, and most importantly in lung cancer, which is the main topic of today. They included up to 29% of all patients, so 27 patients in total in non-small cell lung cancer with a dose of 750 milligram IV Q2 weekly, and the duration of response was 11.1 months, and there's ongoing responses with significant PFS. Hence, this particular medication is an option in this new mutation that we're still looking into for the upcoming future. And with that, these are the main take-home messages. So the field of lung cancer had evolved drastically and changed drastically over the past years, mainly the past 5 years, I would say. And we always have to consider NGS, and I think it's about time that we need to broaden up our NGS with a lot of mutation analyses, especially in lung cancer. And in case of resected non-small cell lung cancer, still there is a new evidence of the use of osimertinib in the ADAURA study, and there is new evidence of the use of alectinib in the ALINA study, which I didn't put in just for the sake of time, and the potential targets of other mutations which might constitute various tumors is still underway, and we need to broaden up our options in this particular cancer site. And with that, I conclude my presentation. And thank you so much for your kind attention.
Thank you very much, Ahmed, for the great talk as usual. Now I'm going to present my friend and colleague, a senior oncologist, Dr. Turki Al-Faya from National Gut Hospital. He will talk to us today about the landscape of immunotherapy in non-small lung cancer.
Thank you, Dr. Mohammed, for the introduction. I'd like to thank Dr. Mohammed Al-Garni and Dr. Kanan Shemari for their great organization and successful meeting over the years. So I'm going to discuss the immunotherapy in non-acquired genomic alterations, advanced non-small cell lung cancer. Best practice for whom? All right, this is my disclosure slide. So we know in lung cancer, we now talk about the histological subtypes. We have adenocarcinoma, we have others, we have squamous carcinoma. And when it comes to non-squam, we always look for NGS. We test for molecular alterations, but for squamous, we don't have a lot of options except offering them immunotherapy. Not only this, but also those who underwent NGS, there are many patients, about 30%, will have NGS negative. So the option for them is chemotherapy plus immunotherapy or immunotherapy alone. And also the KRAS. The KRAS, 25% of patients will have KRAS. They also benefit from immunotherapy. So this is a big part of patients will need this treatment. So this is the landscape of treatment for advanced disease. When you have a patient who have a PD-L1 50% or more, the option is single agent immunotherapy. We have 3 options: pembro, atezo, cemiplimab. When you have a patient with PD-L1 less than 50%, then the option here is to give chemotherapy, different regimens, plus different immunotherapies, many options. But remember, there are also options of dual immunotherapy, nivo-ipi or nivo-ipi plus short course of chemotherapy, or durvalumab plus chemotherapy. So we are going to go back to this slide at the end of this presentation. Remember, long time ago, the only option is chemotherapy, platinum-based chemotherapy. The bar for survival was very low. The median survival was only 8 months. So chemotherapy really is not enough. And with the new advances and addition of immunotherapy, we are now talking about survival of up to 13 months, median survival in the first-line setting. So immunotherapy plus chemo or immunotherapy alone added a lot of benefits. Why we choose PD-L1 in lung as a 50%? Because PD-L1 cutoff is different across different cancer types, but in lung cancer, 50% is the best cutoff because it seems that the 50% is the best to achieve best true positive and best false positive. So when you have 50% positivity, you are ensured that this is a true positive and there is almost no false positive. And it has been validated in clinical trials. We have 3 clinical trials used 50% as cutoff. They used pembrolizumab, cemiplimab, atezolizumab, and you see when chemotherapy was compared to single-agent immunotherapy, the benefit was significant in favor of immunotherapy. Not only this, but when you have higher PD-L1, the better outcome. This is a trial of cemiplimab. You see the blue line, the orange line is the PD-L1 more than 50%. And you can see that the survival is significant with PD-L1 more than 90%. So the message here is the higher PD-L1, the better outcome. The question is, can we add chemotherapy to this group of patients, the patient with 50% and above? The FDA pooled analysis showed that immunotherapy agent, single agent is enough for those patients because there was no difference between IO or chemo IO. The only difference is when you look for response rate. So if you are looking for shrinkage of tumor in a symptomatic patient, then chemotherapy can be added. How about the PD-L1 less than 50%? Single agent does not work at all because you can see in 3 trials, in 2 trials here, the PD-L1 less than 50%, when you give them single agent immunotherapy, no benefits. You can see the curves are reaching each other or even superimposed. So try to avoid single agent immuno in patient less than 50%. What to do? We add chemo. So 50%, below 50%, you add chemotherapy to PD-L1 inhibitors. And these are trials in non-sequem. You see different chemo protocols using also different immunotherapy combination. The PFS is significant, and there is also overall survival benefit, at least in one trial, the Keynote 189, you see 5-year survival is 19%. But again, the lower PD-L1 is associated with lower outcome. And for squam, many trials using different chemo, using different immunotherapy combination, positive trials. The most popular one is the Keynote 407 in squamous, where you see 5-year survival is 18%. Again, lower PD-L1 is associated with lower outcome. The question again, in this group, 1 to 49%, single agent immuno is enough, or we have to always give chemo IO? The message from this FDA analysis clearly showing that you have to add chemotherapy plus immunotherapy in lower PD-L1 expressors. So many clinical trials, the design was to combine chemo or chemo-immuno, but this phase 2 trial is a very good trial because it is the first trial to assess chemo-immuno versus chemo-immuno. So we have many options. Which one is better? Dostarlimab plus chemo versus pembro plus chemo. This is phase 2 trial. There is no significant difference, but you can see numerical improvement with dostarlimab across different PD-L1 expressions. I believe dostarlimab is so good PD-L1, checkpoint inhibitor, and this is a small study. I believe if there is a bigger trial, bigger number of patients, you may see true difference. In approaches, when we treat lung cancer, we try sometimes to avoid chemotherapy. So we use chemotherapy-free regimens, the dual immunotherapy, Nivo-Ipi. This is the Checkmate 227 trial. The Nivo-Ipi is better than chemo alone in PD-L1 positive and also in PD-L1 negative patients. But always in the first few months, if we go back to the previous slide, in the first few months with the Nivo-Ipi, there is always a drop in the Nivo-Ipi arm. So there is more progression and more death. So to avoid this, short course chemotherapy was added in this trial, the 9LA. So 2 cycles of chemotherapy plus dual IO, it is associated with better outcome, and it avoided the early drop in the survival curve. This regimen is so good because you can see PD-L1 negative, more benefit. Also squamous, they showed more benefits. Poseidon is the same trial. They used the durvalumab plus 4 cycles of chemotherapy, and it showed the same outcome. So we come to the very important question. So we know now we have chemo-immuno, but also we have dual immunotherapy plus short-dose chemo. This trial, the Nippon trial, assessed the chemo-immuno versus nivo-ipi plus chemo. This is a closed prematurely because of significant toxicity in the dual IO therapy, but it did not show any big difference. If you look at the subgroup analysis, the PD-L1 negative patients and the squamous patients are the people who benefited from dual immunotherapy plus chemo. Okay, let's go back to the 50% and above. Can we improve the outcome by using dual IO therapy? I think the answer is no, because we learned from this trial, Keynote 598, that the high PD-L1 expressors, they need to have only single agent immunotherapy. If you give dual immunotherapy, you are increasing toxicity and you don't add a lot of benefit. Any more options, not just chemotherapy or dual IO? Can we add, for example, lenvatinib, any other targeted agents to single agent immunotherapy? These are phase 3 trials, negative trials, no benefit in PFS or overall survival. But what is really so striking in the last few months is this molecule, ivonescimab. This is a molecule from China. It's actually bispecific monoclonal antibody. It targets VEGF. It targets also the PD-L1, and it seems that's so impressive outcome. This is the trial of PD-L1 positive patients given ivonescimab or Pembro. Ivonescimab is better than Pembro. So I think it's actually changing the practice. The problem with this study is the Chinese trial. You have to have global population, and we should wait for overall survival. So let me take you through some group of patients who are very difficult to treat. For example, the smoking. Do we have any specific therapy for the smokers or non-smokers? Let us see. So in single agent immunotherapy trials, the never smokers have a problem because they don't respond to single agent immunotherapy. If you look at the hazard ratio in these 3 trials, the hazard ratio is 1 and sometimes more than 1. It indicates that never smokers do not respond. And this is a real world pooled analysis showing that never smokers are not responding to single agent immunotherapy. And this is, again, real-world data to show that never smokers, when you add chemotherapy, they get better outcome. So never smokers need chemotherapy, even if they have PD-L1 more than 50%. And this is 2 trials showing chemo-immuno is doing very well for never smokers. The other issue is the histological subtypes. Do we have any specific treatment for specific histology? Let's see. Single agent immunotherapy trials showing that whether you have squam or non-squam, the benefit is the same. And also the chemoimmunotherapy, the dual immunotherapy, does not matter if there's a squam or non-squam. But what is really changing the practice likely is the dual immunotherapy. Dual immunotherapy is having better outcome in squamous histology in 2 trials, Checkmate 227 and Checkmate 9LA. The Poseidon is the only outlier because Poseidon showed benefit in non-sequin, but the message here is that at least non-sequin will also have some benefit from dual immunotherapy. How about the gender? Immunotherapy in women does not really work well in lung cancer. Maybe the issue is that the females are not well represented in these trials because in general, female risk of cancer, lung cancer in female is less. So you can see that almost 15 to 40% only of the populations in these trials are females. And many trials showing that female may not have similar benefit from single agent immunotherapy. And this is the Empower Lung 1, where you see progression-free survival and overall survival is positive, but in the subgroup analysis, females may not have similar benefit like males. Brain metastasis, very challenging to treat patients with lung cancer because of the brain metastasis. This is the data from melanoma. You see, Nivo-Ipi is very impressive when it comes to intracranial progression-free survival. And we start to see it in lung cancer. These are the data from the Checkmate 227. You will see that patients with brain metastasis at baseline, they have a significant overall survival. And again, this is from the 9LA. The dual immunotherapy plus chemotherapy seems to be very effective when it comes to intracranial progression-free survival. So you need to remember that all of these trials, they included patients with treated brain metastasis. And when you give them immunotherapy, you are actually priming the response. So actually the best is to consider testing the immunotherapy in those with untreated brain metastasis. That is why this phase 2 study included untreated asymptomatic brain metastasis, which also showed a very modest benefit. Finally, STK11 and KEAP1. These are very promising and also prognostic, predictive mutations in lung cancer. We start to look at them in the NGS. So STK11 and KEAP1 mutations are more frequent in lung cancer, more than what we expect, from تقريبا 11% up to 17%. And STK11 mutation, the problem with it is that it turned the tumor from hot tumor to a cold tumor. It is associated with a lower PD-L1 expression, and also the T cell infiltration is less. That is why immunotherapy single agent do not work. The same thing for KEAP1. KEAP1 is associated with lower PD-L1 and associated with lower T cell infiltration. Single agent immunotherapy do not work. So what should we do? Dual immunotherapy will work. These are 3 trials showing that STK11 and KEAP1 is having better outcome if dual immunotherapy is given. And this is a very important ongoing trial looking specifically to the STK11 and KEAP1 plus KRAS mutation, randomizing patient to the standard chemo plus dual plus immunotherapy or dual immunotherapy plus chemo. Finally, PD-L1 negative patients, they do not respond to single agent immunotherapy or immunochemo. This is the data from the Checkmate 9LA, where you see the PD-L1 less than 1%, dual immunotherapy plus chemo is very effective. So this is my last slide. If you go back, you will notice now that if we have PD-L1 more than 50%, then single agent immunotherapy, but try to avoid it in never smokers, in also STK11 and KEAP1 mutations, and probably also in women. You need to add chemo in this situation. In those less than 50%, then you can give any options that has a clinical trial and supportive evidence, but probably not in the negative PD-L1 patients. And for the dual immunotherapy or dual immuno plus chemo, it is the best for negative PD-L1 patients, best for brain metastasis patient, and best for those who harbor STK11 or KEAP1 mutation. Thank you.
Thank you so much, Dr. Turki, for the excellent presentation as always. Do we have any questions from the audience?
Dr. Walid.
First of all, thank you for all speakers for updating and the excellent talk. I have questions to Ahmed and to Dr. Turki. Ahmed, thank you again for update about the target therapy. With what we have now in last ALCC, the update in the common mutation in the EGFR mutations, but we have the Mirboza now, lazertinib, Inventimab, and FLAURA2. FLAURA1. How is seeing now your practice? Are you starting to adapt it because that if you are looking for the trial, that 23 versus 16 is almost 1 year difference. So that's now is a clinical practice change in the common mutation EGFR in the first line?
I think this is an excellent question, and definitely something that I always ponder upon. With all these various options that we have now at hand, it's going to be a bit more challenging to pick up the best options for the patients. I gotta say, anything that is chemo-free is the best, and in my practice. So to be honest, the use of osimertinib on its own as a single agent, it is still something that we still can consider in patients who are frail, cannot tolerate chemotherapy with osimertinib. But I think now the practice is going to be more changing towards amivantamab plus lazertinib as a chemo-free regimen, plus as the fact that amivantamab not only tackles the common mutations, but also tackles the most common resistant mechanism, which is the MIT14 amplification. So then down the line, I think that if I have amivantamab available in my institution, I would definitely use that as the chemo-free regimen with lazertinib. That being said, we all know the logistics and the difficulties that we have from obtaining the amivantamab along with lazertinib. So practically, osimertinib plus chemotherapy is the best option until we have amivantamab in our hospitals along with lazertinib. The moment we have these, I'm changing my practice to that particular regimen.
Dr. Turki, thank you. You're updating us regarding those patients with smoking, gender. How is that with immune therapy? It's really when you are selecting immunotherapy for patient in the NGS, looking for the CTK11 and the KIP1 when you select the medications.
Thank you, Dr. Wali. Yes, definitely. I think we have a consistent data from 3 trials showing that the KIP1 mutation and STK11 mutation are predictive for response to dual immunotherapy or dual immunotherapy plus short course chemo. So definitely, yes, we have to look for it in the first line setting. Yeah.
Thank you.
I just need to have a comment on your question to Dr. Ahmed. Also, one of the options when you look for first line anti-EGFR therapy is look at the characteristics of the patient. For example, patient with brain metastases, those with multiple tumor sites, those with concurrent TP53 mutations, they seem to have better outcome from the intense therapy from amivantamab, lazertinib, or EGFR osimertinib chemo. So those patients, if you have them in the clinic, those are the best who will benefit from the combination.
Dr. Samah, I would like to ask a question to Dr. Alauddin. Dr. Alauddin, when do you think the best time to do the testing for NGS? On the first progression or second progression, or when do you really recommend doing it? Timing.
This is a very good question. The timing of doing the NGS is the first progression. But with the emerging data with the first line treatments, so you need to do it from the first progression. And as I mentioned in the presentation, there's a clear mutation as well, ESR mutation. So you can do it in the second progression as well. So first progression and second progression, because there's a different option of therapy. You can do liquid if you have access for tissue, it's better. But if you're not, non-invasive, you do the liquid biopsy.
Samah, we have a question from Dr. Al-Garni here.
Thank you very much for all the speaker. So I have actually 3 questions. One of the questions already asked to Dr. Ala. So I will start with the question to Dr. Ahmed from non-thoracic oncologist. So you saw or you mentioned the alteration in the targeted therapy. So what is your experience with MIT amplification, not with the skip mutation? Do you offer them the targeted therapy or not? And my question to Dr. Turki is regarding a patient that I have with ALK arrangement, and she's progressing in the second line treatment, and her CPS score is 90%. So is immunotherapy still has a role in those patients, or it's not considered at all in those patients? And my last question to Dr. Sharif. So with all these indications for BRCA and either in early or late stage, do you think we should adhere to the testing criteria, or we can just offer testing for all comers with breast cancer? Thank you.
Thank you, Dr. Hamid. I think the question is outstanding. Even if it came from a non-thoracic oncologist, that was a very difficult question to be answered, to be honest. So when it comes to MIT14 amplification, it is the most common resistant mechanism that we face when we give patients osimertinib. So I have 3 cases where I had given imvonetimab basically as a second-line option without having the test done, with while keeping in mind that the most common resistant mechanism that we are facing is the MIT14 amplification. They had all of them except for one. They had excellent responses and excellent PFS, and one of them actually had lived more than 1 year while being on amivantamab chemotherapy. So that's my experience, while keeping in mind that the biopsy was non-amenable, and that was in line with the Mariposa 2. So when it comes to the MIT14 skipping mutation, which is the thing that we face in the first-line setting, yes, I have experience with the use of crizotinib and tepotinib, and basically patients, when they have those kind of mutations, some of them would have, most of them would have partial responses, and one of them had complete response for over 1 year. So that's my experience. The side effect profile of the medications is the main thing that would dictate how we're going to go up upon choosing the medications that we'd have at hand. But that's my experience with the MIT14 amplification. Amivantamab chemotherapy in the second line is an excellent option.
Thank you, Dr. Mohammed. This is a very challenging case, actually. If there is ALK mutation, not rearrangement, you will see always high level of PD-L1 expression. So you need to go back to the NGS to see if there is just fusion or there is also some element of mutation. But in general, if you look at to the data, maybe the ALK rearrangements or mutations are the most mutations in lung cancer that are associated with higher PD-L1 expression. But it does not mean that they will respond. Unfortunately, EGFR and ALK and ROS1 are the most resistant subtypes to immunotherapy. The exception is for KRAS and for BRAF. They may respond to immunotherapy after they progress on targeted therapy.
Okay. For the third question about the strategies for BRCA testing, thank you very much for the question, Dr. Karmi. Actually, this is a compelling question, actually, and there is a matter of debate about this point. But my answer for that, it depends on many factors. The first is, how is the availability of the test and what is the economic scenario in your institute? If the test is readily available, you don't have any restriction, you can do, I think will be more liberal for the criteria for this. But in my institute, we are sticking to the NCN guidelines for the testing for less than 50 or patients who have another indication like triple negative or a systemic indication also, or family history also. But if you have access and the cost is not an issue, you can be more liberal. You can use the ASCO irrespective of the agent. So, but the next point that we need to consider as well is, with more liberal testing, you will face more patients with a variant of unknown significance, and this is a big challenge actually. And the next point that we need to consider as well is the availability of geneticists and genetic counselor, which we have a shortage for this service, I think, in many institutes. So for the indication for systemic treatment, it may be the role of the medical oncologist can make use of that, and you can guide for the adjuvant or therapy or systemic treatment for metastatic setting. But for non-metastatic patients or patients where the indication of this is a risk reduction strategy, with the basic clinics, you need to consider as well as a shortage of genetic counselor. What is the next step? Who will counsel the patient for the risk reduction strategies? So all these factors need to be considered, and the resources in the institute should be considered as well.
Perfect. Dr. Mohammed, any more questions from the audience?
I think no. I think we're done.
Perfect. Thank you so much. Thank you for our speakers, for our attendance. And I think with this, we will end our session. Thank you so much.
Thank you.
Assalamu alaikum.
Thank you very much for our moderator and speaker. It was interesting first day. So we have come to the end of our first day. Inshallah, we'll start tomorrow at 9 a.m. And for now, I think we can have the dinner. It's in the same floor. It will be served at 6 p.m. Assalamu alaikum.
Assalamu alaikum. Thank you all for attending the first day. See you tomorrow, inshallah, 9 a.m. For those who filled only 1 or 2 attendance data collection sheet, please make sure tomorrow to fill the 3 of them so you can get your CMEs if you are from the targeted audience. Thank you all. Enjoy your Friday. Assalamu alaikum wa rahmatullahi wa barakatuh. See you all tomorrow 9 a.m. All the information you need and you are asking for are available on our app, are also available on the link which we are sharing for the registration. Agenda, how many CMEs, the booklet of the event, all are available there. Thank you very much.